Jetzt ist es soweit. So here we are live from Aachen. I may welcome you, dear audience, on the screens on today's online Congress, Digital Health Now. My name is Claudia Dirks. I am in charge of the communication of the Innovation Health. I'm partner in crime when it comes to the digitization for the health industry and may lead you through the program today. The pandemic has shown in the last long months that lie behind us how immense the role of a functioning infrastructure and trust in digitalization is, and where we stand with it today. Today, we want to shed some light on projects that show that digitization within the meaning of a better healthcare provision is not just an indispensable instrument for doctors, but also for patients. And yes, it's true. I found it rather strange today. The pandemic will not be the topic here in the surrounding of the University Clinic of Aachen, but I would be rather happy if your head heads towards a journey with us throughout Europe. I can hear myself. In the focus of today's Congress, we will have the development or the transfer of a telemedicine healthcare provision, digital healthcare provision assisted by telemedicine in all of Europe for joint action for value-based healthcare provision in Europe. And we want to explore the question what it takes in order to reach that, because currently we still have the time to shape it ourselves. How can referential networks and digital hubs work together in Europe, drive innovation, and accompany the changes in the system? The organizer is the German Society for Telemedicine, the Innovation Center of Digital Medicine of the University Clinic of the Westphalian Technical University Aachen, and the ZTG, Zentrum für Telematik und Telemedizin GmbH. We have great guest speakers, so just two organizational remarks. The genesis of the Congress was like that. We hoped for presence, then we hoped for a hybrid event. Now we're virtual. We are here in the studio. Of course, everyone is vaccinated, just tested this morning. Where the cameras don't reach, we move only around with masks on our faces. So we actually paid full respect to all precautionary measures. And you at the screens, we would like to know your questions and your opinions. You have the possibility on the right or left side of your screen to ask us questions, which we will be most happy to answer or have them answered by our guests. But now I'm really looking forward to open the stage for the official inauguration of the host. Professor Dr. Ulrich Rüdiger is the rector of the University of Aachen. He came back here in 2018. Since then, he has been the dean, has written his doctoral thesis, and 2 years before he came back, he worked as a dean at the University of Constance. And I'm most curious whether he will comment whether it's good to lead a university as an experimental physicist. I'm really happy to have you. Thank you very much. I will answer the question or whether or not if an experimental physicist leads a university, you learn from the very first semester to work on complex themes and topics. If something is really true, then I can say then a university is a rather complex system. So physicists can do it rather well. Dear Mr. colleague, Malz, Mr. Dr. Helle, and dear speakers, my dear ladies and gentlemen, on behalf of the University of Aachen, I would like to welcome you on the Congress Digital Health Now. I'm really happy for this, that we can actually celebrate this new edition, which has attracted many visitors last year and has evoked a large echo. Although there are many positive signs, there have been many positive signs, we still haven't overcome the pandemic. Much more, the situation seems to be more threatening than ever. And I hope that so far you have managed to get through this crisis well And at this point, I would like to extend a thank you to those of you, like you, dear Mr. Marx, who have been fighting against COVID-19 in the front line. The topic of digitized medication is not only important against the background of the pandemic, and is really highly topical, because the breakthrough of digital medicine cannot be avoided. And now it's about time to shape it. To this end, it is necessary that the necessary changes in the supply structure are implemented towards a joint treatment with local and quality-oriented medical healthcare provision. To this end, we need multi-professional, interdisciplinary, and sector-spanning collaboration. Future viable supply structures need to be implemented in large projects from the idea until the very successful transformation in the existing healthcare provision system. And they need to be tested. To this end, you need selected multi-professional locations that are equipped with the all what it takes and to make it usable. This location of Aachen fulfills this requirement as an excellence university which has an excellent campus structure and with the medical excellence of the university clinic. Aachen is giving impetus for the required innovation and the design of a future viable healthcare provision in Germany and in Europe. And this development and the rising need for action in the area of digitization, in order to live up to it and in order to shape it actively, in 2018 we created the Innovation Center for Digital Medicine, or EZDM. Since then, in Aachen, diverse large projects are carried out at the national and EU level, and its funding is safeguarded and its transformation and the ways pay for its transformation in the healthcare provision on a value-based and patient-centered treatment basis under the usage of all that is possible to have in digitized medicine. To this end, we work on many interesting topics: resource saving, intersectoral supply solutions, the usage of digital medicine, or more precisely, telemedicine, AI-based assistance systems, robotics, and further terms I could mention here. The implementation of digital innovation and communication technologies such as teleconsultation, video hours, electronic patient dossiers, and so on. And now I'm delighted to see that the EZDM as a driver and as a shaper of innovative future viable supply structures, especially in the field of telemedical networks, has done a successful job and has successfully established itself in politics and in healthcare field. As is shown by today's event, or as will be shown by today's event, I wish you all a well-done conference day, a successful conference day, so that you may make new findings and that you have good discussions, and I'm really excited to hear about the prize winners of the Digital Health Award. I wish you all the best, and thank you very much for your attention. Thank you very much, Mr. Professor Rüdiger, for this insightful welcoming speech. It was good to have you and get healthily through the year. Now we begin with our journey, and we will hear the initiator. He is director, the chairman, and the president in one person. I have been acquainted with him a couple of years ago, and what I associated with him is resilience, and that he is always in search for solutions. He doesn't have to be presented to nobody in Aachen, but for you out there, we have viewers from all of Europe. Professor Gernot Marx is the director of the Clinic for Operative Intensive Care and Intermediate Care here at the clinic in Aachen, a university clinic in Aachen. Since 2016, he has been the chairman of the German Society for Telemedicine, and that's a co-host of this event. And beyond that, since this year, he's officiating president of the German Interdisciplinary Association for Intensive Care and Emergency Care, DILI, and he will explain. He has been explaining to us very patiently what we'll have to face and what we shouldn't have to face. So the floor is yours. Dear Ms. Dirks, thank you very much. Dear Mr. Minister Pinkwart and State Secretary Herle and Professor Rüdiger, dear Ms. Rosa Fasen, Dr. Klein, dear ladies and gentlemen, dear colleagues, on behalf of the organizers of the German Gesellschaft, Deutsche Gesellschaft für Telemedizin, the Innovative Center Digital Medicine, as well as the ZTE, and the Innovation Center Digital Medicine of the University Clinic Aachen, we are really happy to welcome you on the second Digital Health Now Congress here in Aachen. I would like to thank all the speakers who have come here in person or who participate in the Congress and enrich the Congress because of their virtual presence. So it cannot be said often enough. Here we have 2G+, the 2G+ rule in the studio, and I think this is how we can encounter the event safely. I would also like to extend a warm thank you to Mr. Pinkwart of the North Rhine-Westphalian Ministry for Economy and Innovation. We are really happy that we have made it also this year, that under his patronacy we can award the prize to innovative companies in North Rhine-Westphalia. I think that's an important signal for NRW as a location for telemedicine in Europe. So what are the challenges we face? We all know that the demographic change leads us to an overaging population, structural factors, personal deficits. Healthcare industry in Europe is facing immense challenges. At the same time, our expectations, the expectations of the civilians to a high-quality healthcare provision and contemporary healthcare provisions are rather high. And we are amidst a change not only in a digital disruption and transformations, we are in a boosted digital transformation, which is boosted by the corona pandemic even. Digital transformation in medicine in Europe. What are the opportunities it offers? I think there is quite a large number of challenges. Resource-saving, networking of expertise in cross-border networks, digital shaping of healthcare provision processes. I would like to mention the example, which is an immediate response that was given by our minister, and since then makes available important information for the steering of information in healthcare. The usage of AI for medical provision on a daily basis, blood intoxications. By AI, we can predict a sepsis before the clinic is able to tell us or to reveal it to us. Telemonitoring, assistance systems, robotics. What occurs to me is the assistance in healthcare provisions, in the care, which facilitates the work of assistants in the wards. In order to use the opportunities, we are a really good spot at the campus of the University of Aachen. Here, this is a melting pot of the highest expertise, application-oriented, excellent actions. University Clinic Campus and the cooperation with the accompany, also the transaction of academia in products and in the marketing, and thus making available it for many people, especially in the field of digitization in medicine. This really represents a USP, an asset, and it is our goal here on site to build a cluster for digital medicine in order to enhance the chances and to seize the opportunities we have and to make them a reality in a pragmatic way. The digital transformation of telemedicine in Europe. What do we need? We need resource-saving, networked, intersectoral telemedical collaboration at a European level. We need supply networks in order to modify existing supply structures by means of digital offers. It is our vision to find a focus on the real implementation of digital network-assisted health structures. The bundling of national and regional activities will lead to a prosperous telemedicine and digital networking. Telemedicine in intensive care, that is just one example. 10 years ago, it was launched as a regional pilot project here in Aachen. In the most comprehensive telemedicine study, Telenet NRW, with more than 150,000 study connections, we made it to establish a digital health network here in North Rhine-Westphalia. And this was also the foundation and the basis for the next steps, for the foundations of the virtual hospital NRW, which was the real digital innovation in the healthcare provision landscape in Germany, with the emergency care treatment it was used for COVID and for and it assisted the treatment options of our partners. So let me allow you to remark, the current evaluation said that there was a survival advantage because of the structure of ventilated COVID-19 patients. And this is especially important for this event. This initiative also at European level has created innovative healthcare provision structures. And in the course of the EU project IC for COVID, it will be continued. Networks in intensive care medicine in ICUs in 10 EU member states are currently built up. The concept, better healthcare provision because of research, has proven to be valid in this context, and NRW is a real pacemaker in digital medicine, the digital transformation in medicine in Europe. What needs to be done? The support of idea generators and impetus givers that take up on strategic tasks and think long-term and internationally and solution-oriented and pragmatic. The build-up of European healthcare networks, and last but not least, a comprehensive further training initiative. We need a generation that disposes of comprehensive digital skills. It is our objective to render better healthcare provision, to learn from each other, and it is now. I would like to thank all speakers for their commitment, for their time. Now I would like to thank also the organizational team under the direction of ZTG and Ms. Weber. A virtual congress requires just as much preparation as an event held in the presence of everyone. I would like to thank Mr. Becker, the board members of ZTG and the TGM. Without them, the successful event would not have been thinkable. I wish you all an exciting Congress. Get inspired and get motivated, and use the chat function for your questions and join discussion. Thank you very much. Thank you very much, Mr. Marx. Now we come to the even more efficient part after the rector, after the initiator. We are looking forward to the video message of Minister Pinkwart. He is actually the head of this event, and he can't be here live. Dear Mr. Rüdiger, ladies and gentlemen, the patron, healthcare is a leading industry in the North Rhine-Westphalian economy with a strong potential to growth. Medical and nursing care is considered excellent, and parts of this industry, such as medical device technology and pharmaceutical industry, occupy top ranks. The close cooperation between business, research and care is a success factor and places healthcare as an innovation driver for a modern, supportive healthcare system. Digital transformation here plays a prominent role. Our aim is to expand North Rhine-Westphalia's pioneering role in the digitalization of the health industry, thereby establishing a resilient and innovation-driven healthcare industry and healthcare system. All of those developments and trends hold high potential for adding value, especially for innovative companies and startups in North Rhine-Westphalia, and are in the focus of numerous projects supported with the funds of the EU and the land NRW.
Unter anderem die
among
Transformation
others,
zu
the
intelligenten
transformation to
Krankenhäusern
smart
der
hospitals of the
Zukunft,
future.
sogenannte Smart Hospital.
Yeah, that's
Der
what they're called,
modellhafte
smart
Aufbau von
hospitals, the
digitalen
installation of models
Gesundheitsplattformen,
for
zum
health
Beispiel
platforms
in
such as
OWL
in
oder die
OWL
Datenübertragung mit
or
5G
5G data
in
exchange in
Notfallsituationen.
emergency
Auch im Rheinischen
situations.
Revier wollen wir die Chance
Here in
nutzen
the
und
Rhenish region, we
Leuchttürme
also
für
want to leverage the
digitale
opportunity
Medizin
and
und
develop flagships
Gesundheitswirtschaft
for
entwickeln.
digital medicine and the healthcare
Laut dem
industry.
nordrhein-westfälischen
In the
Startup
North
Monitor
Rhine-Westphalian Startup Monitor
2020 ist der Anteil
2020,
von
the share
Startups im
of startups in the
Gesundheitssektor deutlich
healthcare
gestiegen und
sectors
rund
has markedly
10% der jungen
increased,
Unternehmen
and
sind in diesem
10% of the young
Geschäftsfeld
companies are
aktiv.
operating now in this
Bei
line
der
of
Entwicklung
business. In the
digitaler
development of digital health,
Gesundheitsangebote setzen Startups wichtige Impulse für
ranges
innovative
startups set
Lösungen
important
und werden
impulses for
künftig
innovative
verstärkt
solutions and will in
Produkte und
future offer more
Dienstleistungen
and more
für
products and
Medizin
services
und
for
Gesundheit
medicine
anbieten.
and health. As
Gesundheitsstartups
new
sind
and
als
innovative
neue und
players,
innovative
health startups
Akteure
are
nicht mehr
essential,
wegzudenken und das Feld
and the
der
field of
Startup-Förderung
assisting
ist ein
startups
wichtiger
is an important
Baustein für
component
unsere
of our
Digitalstrategie.
digital strategy.
Nordrhein-Westfalen
North
ist
Rhine-Westphalia is
das
the
Land
land of
der
startup companies.
Start-up-Unternehmen und es ist mir ein
And I'm
persönliches
personally
Anliegen, dass wir die
passionate
vielen
about
Innovationstreiber
supporting the
im
innovation
Land
drivers
bestmöglich
in our federal
unterstützen.
state as
Dazu haben
best
wir in
as we can. To
Nordrhein-Westfalen
this end,
einige
we have
große
initiated
Programme
several major
aufgelegt.
programs
Einerseits
in
die 6
NRW.
Excellent
On the
Startup
one hand, the
Center
6
in
excellent startup centers
Nordrhein-Westfalen,
in
die
North
seit Januar
Rhine-Westphalia, which since
2019 die
2019
Ausgrünung aus
have
der
driven
Wissenschaft
spin-offs
vorantreiben.
from science
Diese sind
institutes.
an den Universitäten in
These are
Aachen,
located at
Bochum,
the
Dortmund,
universities in
Köln,
Aachen, Bochum,
Münster
Dortmund,
und
Cologne, and
Paderborn
Münster and
angesiedelt.
Paderborn.
Andererseits
On the
fördern
other
wir seit
hand, we
Ende
have subsidized
2016
since late
5
2016
digitale Hubs,
5
die
digital
besondere
hubs
Unterstützung für
providing special
digitale
support for
Start-ups,
digital
aber auch für den
startups, but also
Mittelstand
for the
bieten,
SMEs
der mit den Start-ups
that want to work with
zusammenarbeiten
those
will.
startups.
Der DigiHub in Düsseldorf hat
Befittingly, the
passenderweise
DigiHub in
auch das
Düsseldorf
Thema
also
HealthTech
focuses
im
on
Fokus.
health tech.
Dazu
To this
vernetzt der
end,
Hub
the hub
Start-ups
links
und Akteure der
startups with
Gesundheits-
health
und
and medical
Medizinbranche.
industry actors.
Und schließlich haben wir im
And
Oktober
finally,
das
in
neue
October,
Scale-Up-Programm
we launched the new
Scale-Up
Scale-Up
NRW
program,
gestartet.
Scale-Up
Startups aus
NRW.
Nordrhein-Westfalen, die
Startups
dabei sind, zu
which are in the
Scale-Ups
process of becoming
aufzusteigen,
scale-ups
erhalten über das
are
Programm
given
gezielte
targeted
Unterstützung
support
für
by
ihr
this
Wachstum
program
und
for
ihren
their growth and their
Internationalisierungspfad.
internationalization
Da war es mir
pathway.
ein Anliegen,
This is
erneut
why I
die
strongly
Schirmherrschaft für den
felt
Europäischen
about acting
Digital
again
Health
as a
Award
patron for the
2021
European
auch
Digital
in
Health
diesem
Awards
Jahr zu
2021,
übernehmen.
this
Mit
year
über
again.
40 Bewerbungen
With over
sind
40
viele Startups
applications,
dabei und
we
zeigen die
count many
Potenziale
startups
der
showcasing the
europäischen
potential of the
Startup-Szene.
European
Gespannt bin ich
startup
auf die
scene.
besten Pitches,
And
die heute auf der
excited
Konferenz
to see the
gezeigt
best
werden,
pitches shown at the
und
conference today.
gratuliere vorab
And
allen Gewinnerinnen
I would
und
like
Gewinnern
to
von Herzen.
wholeheartedly congratulate all winners.
Genau, Gewinner sind schon alle die heute eingeladen sind, die 10 Startups, die wir ab 16 Uhr hier begrüßen dürfen, um ihre Lösung zu sehen und kennenzulernen. Und nach dem Grußwort von Dr. Pinkwart freue ich mich jetzt auf den Staatssekretär im Ministerium für Arbeit, Gesundheit und Soziales, Dr. Edmund Heller, der von der Wirtschaft etwas wegkommt und nochmal betont, dass die Digitalisierung, wofür wir das alles machen, kein Selbstzweck ist, sondern es immer darum gehen muss, die Patienten besser zu versorgen, Pflegende zu entlasten und Ärzten und Ärztinnen ein Instrument an die Hand zu geben, was ihnen ermöglicht, mehr Informationen zu sammeln und eine bessere Gesundheitsversorgung auf den Weg zu bringen. Ich freue mich sehr. Hallo, Herr Heller.
Hallo, sehr geehrte Frau Dirks, sehr geehrter Herr Professor Rüdiger, sehr geehrter Herr Professor Marx, sehr geehrte Damen und Herren. Digitale Technologien werden die Versorgung von Patienten in den nächsten Jahren grundlegend verändern und stärken. Der Beitrag der Digitalisierung für eine leistungsstarke Versorgungsstruktur ist fundamental. Wer bestmögliche Versorgung will, muss dafür sorgen, dass die durch Digitalisierung dazu eröffneten Möglichkeiten verwirklicht werden. Größte Erwartungen werden an die Entwicklung der sogenannten künstlichen Intelligenz geknüpft. Diese Erwartungshaltung ist berechtigt, aber erlauben Sie mir zu Beginn einen Hinweis. Es sind Mythen zu durchschauen, die sich in der öffentlichen Diskussion um das Konzept der künstlichen Intelligenz ranken. Hat IBMs Computer Deep Blue 1997 tatsächlich Garry Kasparov geschlagen? Wer das behauptet, muss annehmen, dass Deep Blue tatsächlich Schach gespielt hat. Dass er also die Absicht oder Intention hatte, zu gewinnen dass er Spielstrategien entwickelt hat, sich über Fehler wie mangelnde Weitsicht gegrämt hat, sich um einen Springer sorgte und so weiter. Das wäre eine verwegene Annahme. Sie liefe darauf hinaus, dass Deep Blue auch nur ein Mensch ist. In einem aktuellen Buch von Gaspar Koenig, einem übrigens sehr kritischen Begleiter der Entwicklung, lese ich folgende aufschlussreiche Passage über künstliche Intelligenz in der Medizin. Ich zitiere: Man darf die ganz realen sozialen Herausforderungen
not actually compare this and confuse this with the myth of the robots. Robots are produced by human beings before they're replaced by them. Artificial intelligence is the optimized and multiplied combination of millions of human intelligences. And it seems erroneous to me to state, as done in the early summer of 2018, hitting the headlines in the international press, that AI could actually beat 15 leading Chinese physicians in detecting brain tumors. You should rather write that AI has actually enabled an unparalleled cooperation in which thousands of physicians actually label 10,000s of images of tumors. What is so astonishing about this and miraculous about this, that 10,000 doctors actually together produce better results than 15 of their colleagues. So much for Gaspar Koenig. Artificial intelligence is not an autonomous spirit in the machine, not homunculus, but an advanced technology that actually allows us to optimize expertise the way we've never done it before, to multiply it and thereby improving therapy and diagnosis. And this is what this is all about. What applies to AI, pars pro toto, also applies to the whole area of digitalization of the health industry. In the digital strategy of our land government, the health sector actually therefore occupies a highly prominent place. The importance of the digitalization of the health sector can be shown by an example. And allow me to briefly introduce you to the virtual hospital NRW that Professor Marx already pointed to in his welcoming address. A crucial point of departure for this virtual hospital in North Rhine-Westphalia was part of the Innovation Fund and the Telemed NRW project. The project parties, the University in Aachen, impressively demonstrated what and how telemedicine works. Towards the end of the project, the period was 2017 to 2020, so towards the end of the funding period of the project, the question arose, where do we go from here? Do we need a follow-up project? After talking to project owners and after the presentation of the project results, the Health Ministry in North Rhine-Westphalia, in the person of Minister Laumann, quickly realized that a continuation of the work done in the project can only make sense if telemedicine becomes part of standard care. So this was basically the birth of the virtual hospital, because this virtual hospital should not be more than the idea of transferring telemedicine to standard care, as tried and tested by Aachen. Then we established a foundation body with experts from medicine, informatics, and from sickness funds. They actually looked at a variety of legal and medical questions. The structure of the virtual hospital was described and defined, and the starting indications were laid down. These are indications from the areas of oncology, cardiology, and rare diseases. The foundation of the GmbH, of the limited company, took place. The location is Hagen in Westphalia, and a CEO was appointed, and 14 employees started working. The virtual hospital currently works in pilot operation. Contracts with 39 interested hospitals for secondary and tertiary care have been concluded. More than 130 further hospitals for standard care are concretely interested in participating, and the conversations and negotiations are currently being held. On the supply side, those maximal care suppliers are to be included that follow the general care principles by the Bundesausschuss. Together with the establishment process, a pre-pilot stage of the virtual hospital started working, and on the at the climax of the first COVID wave, the University Clinic Aachen and Münster started in March to actually look after COVID patients with telemedicine. In over 3,100 consultations, so far more than 500 intensive care patients were actually looked after very efficiently and very successfully using telemedicine. In a video conference a few months ago, a companion who actually built the virtual hospital was asked whether he could actually put the meaning of this hospital in a nutshell, and he spontaneously said, quite surprisingly, democratization of top medicine or medical care. And I think this is well said and really summarizes the expectations we all have when it comes to digitalization in healthcare. Well, I would like to thank you for your attention and to wish you constructive conversations in the project that I regard as a joint project. Thank you very much. Thank you very much, Dr. Heller, for these introductory remarks. And now that we've developed a feel for the fact that the nucleus of the digitalization of the healthcare system is located in North Rhine-Westphalia, we would like to widen our perspective and look at Europe. I look forward to Dr. Christoph Klein, the coordinator of the European Commission responsible for the digitalization of European industries. And he will actually widen our horizon and actually introduce the European view in his keynote that he will present here physically on site. Dr. Klein, you have the floor. Thank you very much for this kind introduction, Professor Marx. Thank you very much for the introduction. I am really happy, Professor Rüdiger, Dr. Heller. Ladies and gentlemen, it is a joy, a delight to be here in Aachen. We've seen many, many exciting projects, and they have a European nature. And European is definitely a term that actually has a specific place, a home here in Aachen, connected to many other locations in Europe. And what I've brought along for you now are information and ideas and thoughts what the European Digital Europe just adopted a few days ago and finally confirmed what it has in terms of components. Let me tell you that we've learned one thing. Things work out a lot better jointly and on a European level. And what counts now, that we're all heading in the same way. And I'm showing you the big thoughts, the overriding thoughts, but I would also like to show you the components of importance. In the Digital Europe program, or digital in capital letters, The idea is that we actually can achieve main objectives digitally, jointly, and what plays a major role is that we can concentrate on joint action and to create the basics for surviving in a digitalized world, in a digitalized Europe. This Digital Europe program with its sisters and brothers in programs is one important piece of the puzzle. And when you look at all of the various components or pieces of the puzzle, you can see that we're thinking of health, but that it is not a health-only program. And looking around in the room here, I can see the digital industry 4.0, and I can see impetus for all the various sectors that we can leverage. So telemedicine, the connecting of centers of expertise, digitalization. It does not mean that we now do digitally what we used to do in an analog manner. We have to think about processes tomorrow and how we can do things jointly. And this immediately takes us to the point where we have to realize that only in advanced digital skills, so in promoted digital skills, we can find the basis for knowing how to do things better using digital opportunities more efficiently, and being able to work in a far more trust-based way, although we're doing things differently than we used to yesterday. The digital program is very big. When we look at the individual components, let me just pick the advanced digital skills rated at 577 million euro. We can see high-performance computing, cybersecurity, but we can also see, and we heard about this from Dr. Heller, but also in the introduction by Professor Rüdiger and Mr. Marx, cloud and data and AI. This is the fuel of the process. So this is the fuel and the driver of what we can move. In the presentation of our program, which supplements the other programs for medicine, we also see an essential role with the digital innovation hubs. The hubs that were created, as Minister Pinkwart mentioned it, that are already subsidized today and play a pivotal role. They play a matrix role so that we can learn how to make processes more efficient in industry, how we can accelerate processes and actually do things better jointly. And this actually cross-cuts all of the technology sectors that I briefly alluded to, and advanced digital skills and leaving nobody behind. This really plays a decisive role. Leaving nobody behind means not only that everybody has to understand how things work, it also means that we not only in nursing care, where we see that people are stressed out because of the high performance, but we can also change processes in the digital realm. And what we see is that we lack specialists, the experts, and medium-skilled labor in order to instill our ideas with life. If processes in intensive care, processes that are digital, then we also need the people who are trained for doing this, who understand how this works, how they can improve even further, and how they can cooperate. So the ambitions we have in this digital decade, in this decade of digitalization, is to close the huge education and training gap, the skills gap. We know that we have to promote advanced skills, and so this will be a specific challenge, and we look forward to exciting programs here and initiatives and some energy. We do hope that universities, that the training, the education and training units can activate people so that we can look forward to digital pathways where we use the digital realm naturally, where we not feel forced to do things differently, but we're looking forward to handle things differently because it's more pleasant, because it's faster. And in medical care, it's pretty obvious. If specific control processes at the patient's bed, the bedside, can be done remotely, if we can provide care remotely that does not require to don protective personal equipment to enter a patient's room, then it is pretty obvious that these things make a measurable contribution, an immediate contribution, and that actually AI benefits health immediately. We briefly mentioned the hubs and the digital innovation hubs. These close the gap between the local and the European level. Europe is not far away. Not here, definitely. Here we can actually grasp it when we turn towards Belgium or the Netherlands, moving or driving just a few kilometers. But Europe, in digital terms, is of course very close-knit. And when we think about the innovation hubs and how the collaboration in digital development and healthcare can be transferred out of the hubs where we promote development and transfer it to other hubs and innovation centers and into a European application, then it becomes very evident that these hubs and reference centers play an extremely important role for innovation in this area, in injecting innovation in these areas, so that we can understand that what we do is immediately available in the European single market, and that it is immediately available for people. What we learn can be seen and applied elsewhere in Europe. It can be understood and discussed elsewhere in Europe, and this added knowledge value is basically priceless. So the connection of hubs and reference centers really promotes advance and needs to be directly connected with the digital skills to involve people beyond the user and the citizen as active participants who stand a chance of making the system even better and making the system the way they want it to be. Summarizing the digital program, the Digital Europe program, I think these points are all linked. We have high-performance computing that is available to us to do the computational work in a high-performance environment. Of course, cybersecurity is extremely important to make sure that our data is safe, that data is not abused. Then artificial intelligence. This is one of the major building blocks where we have to know how and where to use it and how they fit in with the rest. And we've seen that the digital innovation hubs, together with the programs on digital skills and education and training and reskilling and upskilling on a master's class level, play a crucial role. And so far, I would like to conclude by saying Let us just do it, and let us just do it together, because together we're even better than by ourselves. Thank you. Well, thank you very much, Dr. Klein, for this insight that you've provided us with for the work of the European Commission. Dr. Klein, what I'm interested in, you have walked us through this freshly adopted program. I guess that the lead time was a very long one. Over the past 2 years, when the pandemic had a firm grip on Europe, did you or have you seen a different discussion culture? Do people talk differently about the possibilities of digitalization? Have discussions changed? Well, I think that we're lucky that in Europe and within the Commission as well, we have very flat hierarchies, allowing us to exchange quickly and on a trust-based manner. This developed beforehand, but what we've now experienced is that the necessity to come up with faster exchange has improved even further. Of course, it is a learning curve for all of us, because we did virtual things that we used to discuss face-to-face. This is more difficult. We know this from experience, but I think we've also seen that digital was too slow. It needs to be speeded up, and that digital must be linked more with applications. We're not a digital hub, but we're the health innovation hub, and we actually fostered the network thinking. But we found that the pandemic has Europeanized digitalization. This may also be due to our topic, fast track, and the digital health applications that are now forming part of standard care. We have seen strong interest in 20 other countries, including even Japan. A lot of interest shown during our workshops. I do have the feeling that the European concept or idea has been embraced now. This may be due to the bubble we're currently acting in, but is cooperation in your setting become less local? Are you looking beyond your backyard? Well, I think that during the time of pandemic, we've witnessed how people realize that cooperation is not only important, but that it can also work. And where you had structures that enabled this exchange, everything was possible and easy to do. But where the borders were closed, nothing worked anymore because there was no more exchange left. Yes, we've experienced this. We've witnessed this. And we also witnessed that the reactions were less characterized by red tape and bureaucracy. They were thankful, gratefulness reigned, and being grateful for support. We heard about the example about the collaboration in intensive care for patients. And I think this was graspable immediately and showed that we can actually exchange immediately across thousands of kilometers without any problems. And this was definitely helpful. Would have probably been better to have some human contact in between. But even the Health Sickness Funds Association made a move and removed the cap for tele-diagnosis. I think we can't rewind this wheel, and this really helps telemedicine and patient care on site. I would like to thank you. I look forward to having you again as part of our discussion panel. Now, ladies and gentlemen, we will have our first break, enjoy lunch, and hope to see you back because we will continue our journey at 12:40. We will actually look at Care Without Borders, and we will present best practice examples to show how things can work out more positively for nurses and doctors. Thanks very much, and I look forward to 12:39 when we're all back in front of our screens. Thank you.
Ja, und schon geht es auch weiter
And now we're
hier
back
aus der Uni
here from the
Aachen mit dem
University of Aachen with the online Congress Digital Health Now.
Wer jetzt erst zugeschaltet hat,
Those who
hat
have
schon spannende
logged in and
Impulse,
connected
die wir
themselves
aus
only now will have heard
Nordrhein-Westfalen und aus der
interesting
Europäischen Union bekommen
ideas
haben,
and interesting
verpasst.
insights from North Rhine-Westphalia, and you
Aber
might
im
have missed
Nachgang
them,
kann man,
but
der ganze Kongress wird
subsequently
aufgezeichnet, im
I can
Nachgang
tell
kann
you
man
the
nach
whole
seinem
event will be
Rhythmus und nach
recorded,
seinem
and with your
Tagesablauf
rhythm
die
and
Aufzeichnung
fitting to
sehr
your
gerne
agenda,
noch
you
einmal
will be
anschauen.
able to
Ich
listen to
begrüße
the
Sie
whole
nun
event and to see
zu
it
unserer
again.
zweiten Session,
Now, I
wo
would
es
like to
um
welcome on our
Best
second
Practice Beispiele aus
session,
Deutschland und Europa geht,
where it is about best practice
unter dem
examples
Titel
from Germany and
Versorgung
Europe
ohne
under the
Grenzen.
title Healthcare
Wir
Provision
beginnen
Without
und
Limits.
ich bin sehr
We
froh, dass
begin,
sie sich
and
das
I'm really
einrichten
happy
konnte,
that she was
mit Dr.
able to do
Stefanie
it.
Weber
We will begin
vom
with Stefanie
Bundesinstitut
Weber
für
from the Federal
Arzneimittelforschung,
Institute for
Arzneimittel- und Medizinprodukte aus
Medication
BFA.
Research
Sie
and
ist die
Medical
Leiterin der
Products.
Abteilung
She is the head of the
Klassifikationssysteme
Department
im
of Classification Systems
Semantikzentrum.
and Semantic Center.
Ich freue mich sehr, dass Sie es einrichten können. Ich weiß,
I'm
Sie
happy you
sind
were
ziemlich
able to
deswegen
make it. I
übergebe
know
ich
we're a bit
gleich
under time pressure. This is
Ton
why I
und
give the
Kamera
floor
an.
immediately to you.
Vielen herzlichen Dank.
Thank you very much. I hope you can hear me well.
Sehr gut.
Wunderbar. Dann steige ich
Great. So I start with the matter immediately with my speech for today.
vorstellen zu können.
I am delighted to be able to present you a topic that will keep us busy, very busy next year. The question that you may raise, what has Orphanet having to do with digital health now? To us, with digitalization and the promotion of telemedicine is, of course, always interesting under the perspective of coding systems, where we can deploy devices, where we can make that available, that facilitate your services and that allow for applications on the basis of standardized data. This is why I'm looking forward to presenting to you the topic of Orphanet. It's a component for better care of patients with rare diseases.
Was möchte ich Ihnen heute erzählen?
So what do I want to tell you today? I would like to tell you in brief what it is.
Erklären, wo es herkommt.
I would like to explain shortly where it comes from and make a reference to the previous speech, Orphanet in the European environment. And then I would like to talk about what better care means for patients with rare diseases. Does it mean better care through visibility? And I would like to give you a little outlook.
Was ist eigentlich
So what's Orphanet basically? Orphanet is a large European database which was created by INSERM, that's the French institute located in Paris. That was back in 1997, and then received first funding as a European initiative starting from 2000. We ended it in Germany in 2003. It was established at the Hanover Medical School, so we began to establish ourselves there. Apart from then we have taken on the task from the BIF Fund in 2021, and now we are in our first year, and we are happy to take over the preliminary work and the university work. Orphanet is connected with many a network in Europe, for instance, also in the European referential network that was mentioned this morning. The portal of Orphanet, as a matter of principle, is an easy access to a wide range of information about rare diseases. It offers information for doctors and information for patients, and also for people who code diseases. Apart from information on the disease itself, you also have an access to experts. It also is an information portal for experts that can be accessed by all the operators in the region. And it also contains research data. Here on this example, on the cystic fibrosis, you find the codings on one side of the page, the different coding systems, but also a multiplicity of of content information that offer possibilities for diagnostics, for genetic counseling, and so on. Digital Health Now, I would like to speak about the digital part of Orphanet, which comprises the whole information content of Orphanet. Orpha data you can access via the web. Here you can obtain a lot of data and download them and integrate them in your applications. How about Orphanet in the European environment? Orphanet is in the focus of the EU and is carrying out a variety of projects related to rare diseases, which very often happen with the participation of Orphanet and the BfArM. We from BfArM are also involved in some of the projects. I have listed here EJP-RD, SOLVE-RD, that's a program for rare diseases. That's also a project that is about the unclear rare diseases. SOLVE-RD is about solving the unsolved rare diseases, RD code, and the European Reference Network. It is the aim of all those projects to create better services. Also with a view to digital health, eHealth is the eHealth network, that is the network of the European health authorities that deal with eHealth. Also for the area, they have come to the attention of the rare diseases, and within the pan-European healthcare provision, there are various attempts to regulate the data, to standardize and to work on them in a semantical and syntactical way so that it is possible to forward them without problems. Here, the guidelines on the patient summary, on the patient dossier. You see here, you see the offer codes are now used for patients with rare diseases. If possible, you should use the offer-coded information, which should allow you to get an access. So is there better care through better visibility? What does it mean? Currently, it's true that in the routine coding that is used, for instance, ICD-10, GM, in this outpatient and inpatient healthcare provisions, that does not really consider rare diseases. There are only just a few codes that relate to individual rare diseases, for instance, the Marfan syndrome. But many codes are rather unspecific, and many well-known and less well-known rare diseases hide under them, so that you cannot find the individual rare diseases, and so you cannot fully exploit the potential. Therefore, for a couple of years, in the National Association for People with Rare Diseases, in the NAMSE, there is an initiative in order to display the coding better, also called Offer Ideas, in order to integrate them into routine coding. This is all done in centers for patients with rare diseases, and they are now to be coupled to the inpatient healthcare provision. Complete coding is important. Why is it important? Because we want to know how many of the patients with rare diseases are out there. There are many studies and estimations, but there are not many scientifically sound data for the whole population. This is why it's important to see how many of the typologies of diseases exist in order to adopt the coding. And to us at BfArM, it was especially important that we would not add more bureaucracy to the project. This is why projects that were financed by the Federal Ministry of Health, there was a file, Alpha IDSE, which would offer a simplified and time-saving linked coding of ICD-10 GM and offer identification numbers, so that ideally would arrive at a software solution and the coding personnel would have to code only once. and would have been offered all codes at all two codes of at the same time. So with this, we can ensure the quality and the success. What's still pending in the European framework? You had seen the project Solve ID, but RD code is the question: how should patients be coded who are suspected to have a rare disease but could not yet be diagnosed? So in those cases where you do not know the real root cause of their disease, and these are topics that we discuss and where we will have the possibility to display it in a standardized fashion in the next year's outlook. Where are we headed? In coding in Germany, I had mentioned it already, starting from the 1st of January 2023, patients with rare diseases are also to be coded with an alpha code in all hospitals using Alpha ID SE. So what's under preparation? And is that BfArM will offer information and training on coding with alpha codes in the coming months. And I'm happy that I can give you this information as early as today. We will make available information material around the coding of alpha codes in order to familiarize the parties applying it. Visibility, this to us is clearly a topic also for the Federal Ministry of Health. Through the use of alpha codes, patients can become visible or more visible in the system and can be directed to better care. How do we think this works? I'll give you one example, and surely there are many more possibilities of how those alpha codes can be used in order to have access to comprehensive information, and we would be happy if in the course of this event we could set a signal and could have more development together with others. So in the first step, by coding in the Center for Rare Diseases, for example, this information can be stored in the electronic patient file, and we hope this information will be moving into the electronic patient file. As the next step, we would wish that the next caregiver and the persons given care can directly access the information on OrphaNet so that they can retrieve information about a specific condition by using the OrphaNet code. And then, ideally, in the third step, this specific knowledge should allow the treatment to be adapted to the person being treated and should also reduce the risk of incorrect treatment due to a rare disease, so that this knowledge can be taken along and with this improve the treatment. At the end of the day, of course, we would wish for digital solutions to be able to render a contribution to the overall system so that not only the coding is deposited, but that this coding is used. And here we are really happy that also under all the initiatives that are ongoing in North Rhine-Westphalia, that we can make our contributions so that we can take up our ideas and that some ideas will be talked about in the next Congress. So here once again the contact details. If you have questions on that topic, if you would like to discuss something with us, please feel free to turn to us at any time. We are open for your questions, and you would also find comprehensive information on our website. With this, I would like to thank you for your attention, and I ask the host whether there are questions on my speech. I can see that I'm cut off at least half of my picture, but I'm happy to answer your question. Thank you for this impressive speech. If you could move a little bit to the left, yes. No, the other side. The other left, as we say. So it's blessing and curse of digitalization at the same time. Thank you very much for your speech. So what I find astonishing, the director of the Technical University of Aachen has mentioned this morning how many impulses go from North Rhine-Westphalia to Europe, has spoken about intersectoral and interdisciplinary communication. What I do not quite understand is that Orphanet is settled here in Germany. And why you wouldn't set it up at a European level from the beginning? Do we want to copy anyone, or what are the structures for rare diseases or for the coding and the diagnostics for rare diseases? Very often they remain abroad, or is it a joint project? It is, maybe I haven't expressed myself clearly, it is indeed a European project, and in order to make all the information, which is mainly in English, available for all other countries, there are branch offices contributing to Orphanet. There are meanwhile 42 countries where there is an Orphanet: Germany, France, Italy, and those institutions make available the translations in the country language, in the respective country language, and they involve the countries that are interested so that the feedback can be fed back into the headquarters. So it's settled at a European level, and it's doing good networking and digitization of the project European Health Database. We strive for a collaboration with them, and the ORPHA codes and their usage is something that is thought for the whole of Europe, so that communication goes beyond borders and crosses language barriers with this standardized coding. Once we are able to communicate this standardized coding, how do you look back upon the last 21 months? As far as we know, in Berlin, in Germany, it's true that standardization and semantics and standards and the interoperability have done a giant step into the right direction. In our view, was that essential for your work, or would there have been other possibilities too? So maybe now it follows me, actually. So I think digitalization, which has been promoted very much during the last difficult month, can actually benefit a lot from it. The larger expansion of digital communication and the benefit that you see, or that we have seen during the pandemic, will surely be uplifted, and there will be steps towards a semantic coordination and semantic standardization, and this whole development will be boosted, and we want to get the best possible potential. In our experience, it takes a little bit of time until the time invested is received by the people using it. But the impetus we have seen in the last months due to the corona pandemic, whether we would collect a data set, the standardization in the course of just a couple of weeks, where a standardization for whole of Germany would be developed. All those initiatives should take on the momentum, and we hope it will stay like this also once the pandemic subdues. This, in our perspective, is an opportunity, even if it takes a little bit of time. And surely we would have been happy if some things would have worked or would have existed even prior to the pandemic. But we are on the right track, and every partial component we work on, be it the deployment of Loink or Soma CT, can help a little bit so that in the future we can communicate digitally more safely and faster. Also, this initiative has set up studies and projects also spanning all consortiums. So thanks to Ms. Weber, and I can only tell you it's very immediate. So I can only invite you, if she offers you to turn to her and to ask her questions, you should be happy to accept it. So we can actually look back upon an excellent collaboration with them. But now we would like to move on with our agenda. We will become even more European. We go to Spain. I would like to welcome John Taramengeta from Spain, Institute for Health Service and Research. He is the project leader of Jade Care. It's an acronym for Joint Action on Implementation of Digitally Enabled Integrated Person-Centered Care. He is an engineer with a degree in health management. He absolved the expert study course for health services and the exploration of chronic diseases, and has a lot of experience in the implementation of healthcare provision services in national and European project context, and will now give us an overview and a little insight into care assisting projects.
Hello, thank you, Claudia. So my name is John Charmendieta. As you said, I work as project manager at Cronigune, the Institute for Health Services Research of the Basque Country's public health system. During the next 20 minutes, I will present you JadeCare, the joint action on implementation of digitally enabled integrated person-centered care. It's a joint action co-funded by the third health program of HADEA, the European Health and Digital Executive Agency, with a total budget of 5 million euros. It started on October 2020 and will run for 3 years, ending on September 2023. JadeCare is coordinated in Spain by our team at Cronigune, led by our director, Esteban de Manuel Quinoy. In JadeCare, we aim to contribute to innovative, efficient, and sustainable health systems, assisting them in undertaking health system reforms, and also enable national authorities to benefit from proven solutions in digitally enabled integrated person-centered care. Our goals are to reinforce the capacity of the health authorities to address their system transformations to a digital integrated person-centered care, by supporting them on transferring 4 best practices from the early adopters to 23 next adopters. The consortium is made up of 48 organizations from 17 countries, 23 of which participate as next adopters of the 4 best practices to be transferred. So we have systems from all Europe covering different funding systems, both Bismarck and Beveridge, and regions with different level of penetration, adoption, and maturity of integrated care. The 4 original good practices that are meant to be transferred to the 23 next adopters were selected by the member states of the steering group of health promotion, disease prevention and management of non-communicable diseases in 2018. They are the Spanish Basque Health Strategy in Aging and Chronicity, integrated care, the also Spanish Catalan Open Innovation Hub on ICT supported integrated care services for chronic patients, the German Optimedis model, population-based integrated care, and the Southern Danish digital roadmap towards an integrated healthcare sector. The representatives from those original good practice broke down these practices into their main blocks. The Basque Health Strategy in Aging and Chronicity was developed in the Basque Country in Spain and intends to improve the health and quality of life of the population, enhance the health system quality, efficiency, and sustainability, and the collaboration with social services and the community. The approach focuses on risk stratification, digitally enabled integrated care, and patient or citizen empowerment by means of new organizational models, professional roles, pathways and processes, and digital tools and analytics. As you can see, we organize the practice in 3 main blocks, according to what I presented. And this practice is being transferred to 9 next adopters in 8 countries. The Catalan Open Innovation Hub on ICT supported integrated care services for chronic patients was developed in the Catalonia region in Spain and consists of a network of entities that promotes synergies among relevant stakeholders of the Catalan health and social care system. It places the focus on people and guarantees the healthcare continuing with support of digital tools, complementing the individual approach with a population-based perspective. This original good practice was broken down in 5 main blocks. They are health risk assessment, promotion of healthy lifestyles, vertical and horizontal integration experiences adopted in the region, Catalonia, innovative assessment and regulatory issues, and digital support to integrated care. In this case, this original good practice is being transferred to 5 next adopters in 4 countries. Third, the Optimatis model, population-based integrated care, was developed in Hamburg, Germany, and targets simultaneously better population health, improved patient experience of care, including increased service quality and higher patient satisfaction, and reduce per capita cost of health by increasing system efficiency. It was broken down in 6 main blocks. They are shared savings contract with reimbursement or commission organizations, a model including a strong stakeholder engagement, electronic integration across providers, patient involvement and empowerment, data-driven management, and prevention, health promotion, and public health. In this case, this original good practice is being transferred to 7 next adopters in 6 countries. And fourth, the digital roadmap towards an integrated healthcare sector was developed in the region of South Denmark and consists of the SAMB agreement that connects the health sectors digitally supplemented by a number of projects in the area of digitally enabled integrated care. It consists of 2 main blocks, cross-sectoral digital communication, standards and agreements, and then the second one with additional solutions to support complex disease areas. This OGP, original good practice, is being transferred to 8 next adopters in 5 countries. So all the 4 original good practices cover some common principles: care integration, chronic conditions, multimorbidities, frail people and patients with complex needs, self-care, prevention for population health, disease management, case management by means of risk stratification, digitally enabled integrated care, patient empowerment, and regulation. Before we started with the joint action from the coordination of trade care, we launched a series of surveys to gather the maturity of the integrated care deployment of the next adopters and their commitment and ambitions for trade care. We noticed that 11 of them, almost half of the next adopters, have already begun the transformation to integrated care system. 6, about 30%, are in the middle of the process. 5, representing the 22%, are mature enough for practice scaling, and 1 of them is just beginning the process. On the other hand, 15 of the next adopters, about the 65%, had the ambition to pilot the transfer of best practices during trade care. 7 of them, 30%, to increase their implementation capabilities, and 1 of them to carry out a system-wide transfer and implementation. Also, the areas of interest of the next adopters varied, but the 78% of them were interested in embedding the digital technologies and tools in care services. 65 of them on the use of patient-reported data, and for example, the 61 of them on the reorganization of patient pathways, which is very much aligned with the features of the 4 original good practice that they are transferring to the systems. So due to the heterogeneous interest of our next adopters, we saw that some of them were willing to transfer a full ordinal good practice to their ordinal site, example in orange. Others, only some of the features of one ordinal good practice, the example in blue, and others, some features from different ordinal good practices in which we called following a mix and match approach. So we started working on a transfer strategy to make possible that each next adopter customize the parts of the original good practices that will be transferring and adapting, taking into account their needs, local strategies, and implementation. So first, to ease the transfer of the original good practices, we broke down the practices into blocks, as I presented before, but also the blocks into their core features. This way, next adopters could better identify which core features were they willing to transfer to their local sites according to their situation, strategies, needs, and current implementations, as I have mentioned in the previous slide. This is the example of the blocks and core features of the Basque original good practices. So to face this heterogeneity in the transfer of the original good practices, and considering that the transfer will focus on the situation and preparation of the local environments of the next adopters for the implementation, we designed a three-step implementation strategy adapted from the one we designed in a previous unit action, Prodis Plus, that consists of the following. A pre-implementation phase to define the local good practices that will be implemented in each next adopter site and the action plans. An implementation phase to roll out and run the implementation. And a post-implementation phase to analyze the implementation and report the results and learnings. All the 6 steps of this strategy are meant to be performed by what we called the next adopter working groups, which means the local teams responsible for conducting the implementation of the local practices in each site during the year. These groups are made of experts that provide knowledge and faculty on specific matters, decision makers to provide strategic vision, support, and sponsorship and solve bottlenecks in the implementation process, frontline stakeholders to give knowledge and expertise on real-life practical experiences, choose the right type of subject to implement, motivate, and empower implementers and the team to support them to deal with their implementation, and of course, also people in charge of the implementation itself and organize it. So let's go now phase by phase on our strategy. Firstly, the pre-implementation phase has 3 main steps. The first step is devoted to define the scope of the local interventions. This is the features of the original good practices that will be transferring to each of the next adopter sites. For this, during the first months of the project, the original good practice representatives provided detailed information on the implementation of their local features and all the details to guarantee the sustainability of the practices. And the next adopters analyze their needs to then reflect and decide the core features that will be transferring finally to their local settings. Then, in the second step of this pre-implementation phase, the next adopters analyze their situation through a SWOT analysis, identifying the main strategic intervention areas to be addressed during implementation after identifying their weaknesses, strengths, and so on. Finally, in the third step, and taking into account all the information generated in the first 2 steps, The next adopters working group defined their local good practices and the implementation action plan. This is what will be they implemented in the local sites and when, by whom, with key progress indicators and so on, key performance indicators, sorry. This phase runs for 1 year. In fact, we have recently finalized it successfully. The second phase, the one devoted to the implementation, consists of performing 2 plan to study act cycles to implement the local good practices defined in the pre-implementation phase. We selected this PDSA methodology as it is a pragmatic scientific method for facilitating the adoption and testing interventions in real and system level using an iterative approach. The steps of a PDSAI cycle are plan, to plan the actions to be implemented in the do step, do, to carry out the action and collect data to document any problem or unexpected observation, study, to analyze the data obtained during the do steps. This is the key performance indicator. And then the obtained results are compared to the predictions and the learning is summarized. And an act steps to refine the intervention based on the lessons learned and, if applicable, determine modifications and improvement to be implemented in a new PDSA. This phase lasts for 14 months. It has just started and will run until the end of the year 2022. And finally, the third and last phase, the post-implementation phase, is designed to analyze the implementation process and then report, as I said, on results and learnings. To analyze the implementation process, we will use the consolidated framework for implementation research, the SEFIR, that allows analyzing the factors that might have influenced positively or negatively the implementation process. And then for the reporting, we will use the Square 2.0 guidelines, which is intended as a guide to authors reporting systematic, data-driven efforts to improve the quality, safety, and value of healthcare. In JCare, we have planned specific work also to contribute to the sustainability of the local good practices at next outdoor sites by sharing my findings, assuring cross-facilitation at the national, local, or regional levels by supporting the exchange of knowledge and expertise on implementation by the next adopters. We have carried out study visits to the original good practice sites to help next adopters consolidating their local good practices and action plans. And also we'll organize face-to-face workshops between the original good practice leaders and the next adopters during the implementation. Also, we will try to achieve this by generating recommendations and guidelines during the transfer. We will publish, in fact, a blueprint on learning from good practices at the end of the joint action, and also providing results and documentations to reinforce the capacity of the national and regional health authorities to transform their health system to an integrated personal health care system. And finally, we will also try to encourage the sustainability of the practices with plans for actions at local, regional, and national levels. So to end with my presentations, during JCare, we will work to improve both collaboration and trust among the participants, support knowledge transfer and learning, generate evidence and ensure the sustainability of the practice to try to produce benefits beyond it. And we expect to contribute to the creation of innovative, efficient, and sustainable integrated healthcare system to achieve the digital transformation of the health services involving all the needed stakeholders. And finally, encourage innovation, enhance the sustainability of health system, and improve their healthcare performance and outcomes. So this is all from my side. Thank you very much, Dankeschön, and thank you for your attention. I'm open now for questions.
Führungen, Herr Taramendieta.
Thank you very much, Mr. Charan Mendieta. We will also have you on the panel a little later. So just one brief clarification question. What are the targets that you have already defined? When will JADECA be considered as implemented successfully in the regions? And does the Institute measure this itself, or can the regions analyze themselves based on the study design you've laid out?
They will analyze themselves. So we will succeed if they can transfer and adapt any of the core features of the original good practices into their local systems and adapt them to their actual implementations and make them sustainable. So, but they will measure their own defined key performance indicators.
Okay. Haben Sie vielen Dank. Wir sprechen uns nachher noch.
Well, thank you very much, and we'll talk to you later.
Ja, ein kleiner Ausflug nach Spanien.
A little excursion to Spain, very interesting. Oh, it was an impulse speech from Spain that is conveyed into the regions at a European level. Now we go back regional, but also evidence-based. I'm looking forward to Professor Dr. Carina Bentström. She has actually a home run here. She's the academic head of the Innovation Center for Digital Medicine at the University Clinic of Aachen. So she's a co-host, so to speak. She's junior professor for evidence-based health research, and accordingly, she's doing research on patient-centered new digital supply forms and guideline adherence in emergency medicine, in intensive care. Dear Ms. Dirks, dear colleagues, dear audience outside there on the screens, my previous speaker have shown in a very impressive way about a digital assisted healthcare provision in Europe and this diverse potential that we were able to show here in a very convincing way. This is why I'm all the more content that I can talk about the potential of research, and here especially the potential of research for COVID-19 research. In the forthcoming minutes, I would like to introduce you to our new project, Universitarian Telemedicine Network for COVID-19 Research. Those numbers, those sketches here are well known to us, to all of us for 2 years, but I would like to direct your view on the first 100 days, because that is how long it took until we were able to have the first described cases with the newly described SARS-CoV-2 infection, until the time when the World Health Organization declared it to be a pandemic. For Germany, quite topical views of this morning, the pictures of this morning, the waves is different. The fourth wave has fully reached us, and we have heard it in the news. The specialty about these new times is that every time research data reach us on especially important, relevant questions, so we lacked them. Since the beginning of the pandemic, the most various key players have asked themselves different kind of questions in the most various situations. A question about the incidence, diagnostics, therapy, prevention of a COVID-19 infection has kept us very busy in all aspects of our life and has touched us. Here, what we need is What we especially need is research data in order to be able to give an answer to relevant questions and to give our answers evidence-based. A special thing that will be in the attention, in the core of the attention, is long COVID. Here, it is true that currently, and this we have been knowing for the last 6 months, we miss structured longitudinal data in order to make long-term predictions due to a long COVID infection and in order to be able to describe them more in detail. The RKI has summarized this rather well for us last summer. Increasingly, and also in scientific studies, this is described, there are different and diverse problems, health problems going along with long COVID, and it's true that our studies don't allow us a very detailed assessment of how many patients are affected by long COVID after a SARS-CoV-2 infection, or which factors promote or protect against the occurrence of long COVID, or which patients are especially endangered by this disease pattern. What we need here is root cause and healthcare provision research in order to be able to close our knowledge gaps. And here, that's our new project, the Universitarian Telemedicine Network for Long COVID Research, because this is our starting point. We do not know enough. We lack the sufficient data in order to question patients after a COVID-19 infection, after they are dismissed from the hospital. We have big gaps here. We know it from other research scenarios. We have a hard time to question patients after they have been dismissed and to track them after they have left the hospital in order to develop in a structured and evidence-based ways categories so that we know which patients are relevant, what are the process variables we have to look after. And so far in Germany, we haven't had a universal system, for instance, a telemedical research structure at German university hospitals that would allow us to close the gap. Also, patients that we have seen in the ward after or with a long COVID-19 infection, so that we can further assist them. And it is exactly this challenge which is addressed by the Universitarian Telemedicine Network. That is a project funded by the Network of University Medicine. It's a new fund initiative launched by the Federal Ministry for Education and Research. It was launched by them last year. And here it is about building up a research network for Germany so that facilitates cross-universitarian work and to bundle all the research activities. We have seen very impressively that we can only act and or arrive at results swiftly if all the experiences are bundled. For those who are interested among you who want to learn more about our network, I have written the link here. The Universitarian Telemedicine Network is now a new project that has become eligible for the second funding period. We have received a funding recommendation already, and the project start is envisaged for April 2021, subject to the new national budget. On January and February, it will bundle and structurize the research activities for Germany. What are our goals in this area? On the one hand, we want to achieve a high-frequency standardized electronic data collection and integration of as many patients as possible for COVID-19 research, so that we can say more quicker on an evidence-based level for COVID what the risk factors are, what are meaningful measures, what are meaningful interventions for this disease patterns the patients are subjected to, and how we can establish intervention that actually promises alleviation of the problems. And it is really important to us to develop guidelines for the telemedical healthcare provision. This will affect most various areas, outpatient and inpatient, and on the wards, and it will also comprise all the medical aspects that are of importance there. Our speakers are Professor Dr. Gernot Marx from the University Clinic in Aachen and Professor Dr. Anja Schneider from Bonn, University Clinic of Bonn. So we managed to get on board all important German university clinics and further partners. As you can see here on this slide, you have seen here in the first funding period that research and its establishment in healthcare provision is only possible if the major key players practical people from the clinics and researchers, but just as much our decision makers are all seated at one table, all sitting in one board. It is only then that we can make good decisions for our citizens and can establish them. It is our approach not to reinvent the wheel, but to go for existing medical structures for Germany and to build up on them. And of course, we plan that the other infrastructures, the other project of the network medicines are used just as much as the initiative for medical informatics. It is our goal that we have an interoperable, safe and standardized telemedical structure that has an access to the locations participating. Just to mention the NEM locations as node, as hubs. Only this way will it be possible to have a timely collection of large data sets at low cost to support knowledge generation for COVID-19 research. And you can see here, our day has shown that it is really easy to imagine that this principle, this structure, could also go cross-country. So that it could work for all countries of Europe. The structure of the Universitarian Network, University Medicine Network, and the Initiative for Medical Informatics, I would like to introduce to you. We need a good system of board and management, just as much the NUM coordination and the Scientific Advisory Council play a big role, and representative panels and bodies that we can use for infrastructure for the generation of telemedical data sets. We will surely need them apart from the clinical stakeholders. Those are the institutional stakeholders, but also the technical stakeholders. These three aspects are really important so that after 1 year of funding period, so that we can arrive at very good results. Our use case will be to describe the consequences of COVID-19. We will show that what the added value is in the high-frequency telemedicine research data collection. And here, the special thing I would like to emphasize is that we can raise the data longitudinally by means of telemedicine. So with this step, we can not only do it one time, we cannot only collect patient data one time, but it will lead us to many diverse time points in which we will be able to do that. This is an essential point. The study participants will render a very active contribution by providing their own data via an app or via televisits. So it will work independent from time and place, and it will also involve university hospitals, non-university healthcare providers and patients, and people will be able to insert the data on their infection from their couch, actually, in their living room. So, thank you very much. So the second part of our use case will it be to describe the development of evidence-based guidelines for telemedical care and distance learning in Germany, and to develop it. So one core element will be that we will systematically record and evaluate evidence gaps that can then be closed by further research projects in the future. This is the goal, that to systematically record and evaluate evidence gaps, so that later on other partial projects we can feed it back in the NAPCOM cohort or in the intervention platform, that it will be stored there. So it is really important to us that here, with 1 year of research time, haven't come to the end. It is important that the paramount goal is for Germany to have a sustainable telemedicine infrastructure that will be effective in managing future crises beyond 2022. So it will be really easy that this structure, this infrastructure, when needed, can be activated in order to obtain relevant player for the most various questions. And with this, I would like to close my speech, and I'm looking forward to your question. Thank you very much.
Frau Professor Benström.
Professor Dr. Benstö.
Sie haben das jetzt sehr leichtläufig
So you
erzählt
explained it in a
als
very
sozusagen
easy
der
way,
natürliche Lauf der
as if
Dinge
it was the
gewesen,
natural
dass
cause of things,
das Auftreten einer
that by
europaweiten Pandemie die Universitätsmedizin
that with the
mehr
European-wide
zusammengerückt ist,
pandemic,
dass allen
university
versprochen hat,
medicine has come closer
dass
together,
Vernetzung
and that there is
viel schlauer macht und
networking,
dann an
and
dieser
it
Stelle,
makes at all
neue Wege
sides, and that it
einschlagen
makes
muss.
everyone more intelligent,
Das
and
war
that
ja
it's really more smart to go for new
von außen
ways.
betrachtet auch so.
Seen from the outside, that was true, even prior to the pandemic. So the process, what did you find most surprising, and where did you feel the biggest hurdles? So what surprised me most was the individual, how the individual would go away or step back from their own personal goals, and here where they were able to think out of the box, the most various players that we have from the most various locations, everyone's taking their own input and makes it available to the projects, which make it a whole good thing. So we generate and evaluate the evidence, but there's also the important aspect of clinical healthcare provision and stakeholders from the expert society, AWMF, the RKI. And because of the different perspectives, it will be an infrastructure that you can rely on in Germany in the case of crisis. You mentioned the word interoperability, safety, and cross-location. 2 years ago, this wouldn't have been thinkable. I think how vivid is the discussion, or how vivid was the discussion, which data to take up, which data to include, and how to code it. We talked about the topic, and the standards have made giant progress, but nevertheless, it is one thing for experts to agree on one thing or for which data to decide in the end. It's true, it's a big challenge. We pursue the approach that not everyone decides it's for themselves at the kitchen table, but it's an interplay of the most various perspectives, and that we set up on existing preliminary works from existing infrastructure like the MAE, and we can resort to that data. At the same time, there is also scientific evaluation that was done before, which data for which population, for which question are really relevant and patient-centered. And if you take 3 aspects, then you have a good data set that we will pursue. And we will continue to pursue that in our panel discussion, to which I would like to invite you warmly, and we move on.
Entschuldigung, ich muss meinen Zettel hier. Wir kommen von den Leuchttürmen.
So we're moving from the flagships to the model regions now, and I'm very happy to welcome Professor Dr. Christiane Wesen. She is the chairwoman of the Special Purpose Association. It's a regional development association designed to improve the quality of life in the Aachen region, but also focuses on neighboring countries, correct? Yes. Well, thanks very much for this kind introduction. And I think I can follow on well from the previous speaker, because we're also about building networks for the benefit of patient care and to promote the healthcare industry in our region. We kicked off with this overview to show the flagship projects for digital medicine or healthcare in the region of Aachen. You will find some logos already shown in the previous presentation. So there is a wide variety of competencies, and there is a unique situation within the region. On the one hand, we have an outstanding technical university, and on the other hand, we have an outstanding university clinic. And if we actually succeed in linking these, then you get telemedical solutions for digitalization in medicine. And we said this is an important point to actually embed this more strongly in the region. Doesn't work? Where do we stand today? I've brought along some examples through the electronic patient file. We have a cornerstone for digital health system. We have a telematics infrastructure above and beyond their digital health applications, then medical devices as supplementary digital aids, and there is a wide variety of projects busy with finding solutions applications for both in and outpatient applications. The real flagship is the virtual hospital NRW. This is highly specialized expertise that actually works on a cross-sector basis, but also is available nationwide, which of course means a quantum leap for patient care. Somebody else is clicking my clicker. Where are we headed? We have this wide variety of high-tech projects that have been completed. All are very successful. Now, the resulting lessons learned should be made visible and should be implemented within the region. So it is to ensure patient care, especially in the rural areas. Then the technical innovations are to be used for actually using resources more efficiently, and we want to increase the quality of care in rural regions, and we want the cross-sectoral care that is so important to move from one-off solutions to a modular overall system. One of the most important cooperation partners, Professor Mark, said we have to go beyond this. We have to take the European view, and I think that our regional approach maps a wonderful lab to actually get going in this direction and to bring this idea home to you. I somehow have to click or operate this thing differently. Within the region of Aachen, Aix-la-Chapelle, this is the westernmost region in Germany, we have a so-called regional organizational structure that also exists in 9 other places in North Rhine-Westphalia. And now we look at this as the Rhenish region, because as we have to stop soft coal surface mining, we are looking for other alternatives to make industry and economy prosper again. And to reach a status quo here, we actually commissioned a study with the Fraunhofer IMW to see what is available in terms of scientific excellence, and based on a business study that was carried out last year as well, what is our economic capacity and how can we reconcile the two? On the top chart, you can see that the area of digital medical care or medicine is one of the areas that really stands out because there's excellent research outcomes, and they have already been implemented too. But when we also see that there is a huge healthcare market as well, then it is self-evident to actually link these two areas even better than was the case before. And this is what we want to do in the Rhenish region. In the map, you can see how the region of Aachen, Aix-la-Chapelle actually fits in with the rest of this Rhenish region. You can see the challenges. This is the surface mining areas that will be shut down, plus the power plants. So many jobs will be lost. And on the other hand, there will be a transformation process required of the industry as a whole. And this is also one argument why we've said patient care needs to be transformed as well. And we want to do this by way of example in our region. I'll skip that chart and continue here. Of course, we can already see a digital watershed in medicine today with the resulting challenges and opportunities. At present, we have a strongly limited, very inflexible funding framework. Then there's a demographic development with the growing care needs because people are getting older and, of course, have to be taken care of well. Then we suffer structural and staff deficits, which actually became evident or still becomes evident during the COVID pandemic. Then there is a strong progress made in medical device technology, and there is a rising quality expectation by patients for an up-to-date healthcare. And there are the opportunities. So how do we get the existing expertise linked up while saving resources? And how do we actually use this to create a care system for the whole region? Then we want to actually design care process digitally using telemedicine. And we, of course, want to use artificial intelligence for medical treatment in everyday and thereby achieve quantum leaps. And above and beyond, we want supportive technology applications such as telemonitoring, robotics, and assistive systems. These are technologies that are well accepted by patients and that are really important to test. The challenges of digital medicine go one step further because on the one hand there is the healthcare challenge, but on the other hand the challenge of how do we sort out the transformation for economic players? How do we succeed in supporting startups in such a way that they can become prosperous scale-ups? Because the startups in the health industry or healthcare industry face a problem because they lack the access to customers, to industry experts, and to paying authorities. And they also lack the competences in medical device approval technology. So they need support that they can really operate successfully with their products on the market. So they need startup funding, but also scale-up funding and business administration knowledge and access to staff. This is of central or pivotal importance. We need technical information, but they also have to have people that look at the business administration part. Then they're the well-established digital health and medical device enterprises in the region, but they also lack certain things, such as access to innovation drivers from startups and science, at times even access to customers and their needs. And they often also lack the know-how and resources to develop and scale up digital business models. They have to take a close look at this to be future-proof. And all of this is to be done in an excellent network for the area of digital health. There are business ideas that we can convert into high-quality health care, make them marketable. We need complementary partners for development because many things are only possible today by or enabled by multidisciplinary cooperation, and we need a controlled network, a structured network. And this is why we initiated a project called Digital Health Innovation Hashtag Zukunftsrevier, reflecting our contribution we want to make to turn this region into a future-proof region. This intention or this project wants to promote medical care, so telemedical cooperation based on a care network. Then we want to develop and test AI-enabled diagnosis and care systems for everyday medical treatment, but also supportive technology applications are to be developed for telemonitor, robotics, and assistive systems. And we want to be a real-time lab and a test environment. And for the business development, just as important, we want to actually establish innovations from digital healthcare and medical device technology so that the industry can use these elements to grow faster. We want to realize cross-innovations. Right now, this is one of our central jobs within the Aachen region. We say, for instance, the innovations from healthcare and mobility are to be linked. How are logistics issues to be solved better by hospitals? How can the transport of patients and products be organized better? And this actually leads to cross-innovations when you look at other fields of innovation. And it is about developing and testing products in a digitalized, connected health market. So we come from the digital transformation in medicine, in the medical field, but also want to create a transformation in the Rhenish region because we want to transform the health market there and develop it further as well. In this chart, you can again see the individual pillars of this system and the project that we want to put into practice. We have the health market on the one side, the startup incubator, and the company builder that actually wants to accompany companies along their transformative journey. And all of this will be implemented. We have defined target groups, of course, the paying authorities and patients. When you look at healthcare, then there are the startups and there are the well-established companies. And if these three target groups are dovetailed in such a way that they can benefit from each other, that scientific actors in the medical field can share their knowledge with startups and well-established companies, then our aim is to create a model region here in this region. And we will hopefully implement this in the Düren region, which is one of the central districts, and it is strategically prepared to grow. Düren says we want to actually move people to settle down in our region, and an important pillar for doing this is, of course, proper healthcare and innovative jobs or jobs in innovative industries. And what you see here are the project partners who have joined or embarked together on this journey. Science, business, and regional actors are brought around the table to put this into practice. I think it will only work out because we need each other in order to reconcile the various competencies and the resulting possibilities. With this model region for digital medicine and the health economy, we're building a bridge between medicine, science, technology, and business. And with this, we want to make an important contribution to the transformation of our region, to build this health ecosystem for digital medicine and medical device industry. In this lab region, we want to learn and we want to create a blueprint for actually installing further nuclei in these regions. And we want to anchor it on the European level so as to really improve healthcare in the region and across Europe. And this is why we are delighted to really implement these brilliant ideas. And I look forward to your questions. Thank you very much for this impressive presentation and for the colorful bouquet of elements under the label digital medicine. But this multidisciplinary approach you've taken and intersectoral or cross-sectoral approaching many different industries, you've really described a pathway so well. You are lucky here because you are really in an innovative hotbed. Do you think that you can transfer this to other sectors of industry? Well, I think if we can really succeed in getting this cooperation going and developing this model region, I think there are many approaches to also transfer this to other lines of business. When you're successful doing something, then you can transfer it. And I am absolutely confident that we will be successful because we have found a body composed of high-quality scientists, high-quality entrepreneurs, and the regional actors. And this is why I think that quality will prevail, and it will be a best practice for others. Could you provide us with an insight into your everyday work? Do you have an advisory board or a body that actually tables ideas, and who decides about what is actually taken up upon? Or in Düren, for instance, how did you come up with this? We're in the early stages of the process. We have actually introduced an outline, actually submitted this to a body, and we are very confident that it will be eligible. And as soon as it is selected, we will actually implement it. But we already have a wide variety of actors working together. Currently, we have a regional project with the same actors cooperate again, knowing that they can rely on each other, and where digital health and mobility are dovetailed. Health, mobility, and digital medicine. And there we are developing innovation partnerships. And these innovation partnerships also resulted in this. We have to think bigger. That was the idea. And we will the question about an advisory board, of course, we also need external input. So these will be the next few steps over the next weeks and months so that we can really get going next year. We are in the three-country region. Have you found any role models or examples from other countries, or does this originally come from Aix-la-Chapelle? In the Netherlands, you've got the triple and the quadruple helix. So you anchor innovative things if you take business, policymakers, science, and people. And there's some examples, especially in the Netherlands, that show very nicely that such concepts in other lines of business work really well. To not anticipate the whole panel discussion, but I look forward to a little later. Please take a seat and you will stay available for further questions. Again, my request, use the opportunity on the screens to ask questions, and we will actually pass on these questions. These can be very concrete questions, but you can also touch upon the meta level, and I'll see you later.
Hallo, da sind Sie schon. Zu Gerlinde Benzog. Sie ist Mitglied im
Gerlinde Benzog, she's a member of the German Rheumatism League, Federal Associations. She has been given the honorary order of the country of Berlin. She takes us on a journey into the world. She has the Order of Merit, and she takes us on a journey into the world of the chronically ill. And also, this is an area where we need digital solutions. We do not pursue that as a means to its own end, but it only makes sense where it actually improves daily life, the quality of healthcare provision, so it will not become cheaper. This is not something we should be misled by, but it will unfold its effects as soon as you start using it. Ms. Bensruck, I'm really happy you're here. For years you have been committed to patient empowerment. You're a member of the expert body Care for Ziri. You are the chairwoman of the Federal Association, and you are a point of contact for 65,000 people with physical impairments and chronic diseases, patients. And one thing I should not forget, she's a studied cultural manager. She's also the managing director of the Institute for Cultural Market Research. I'm happy you're here. Thank you for this rather comprehensive announcement of my person. I will talk to you today from the perspective of the chairwoman of the board member of the German Rheumatism Federal League. Maybe that wasn't transported that quickly. I'm really happy that I can now have the possibility to make you hear the voice of the patients, of the patient advocacy groups, and so that it will have a forum here. Ms. Professor Fresen said it, quadruple helix, the four-clover leaf, a sustainable quality in healthcare provision. With digitalization, you will not reach if you will only achieve if you involve all the important stakeholders from the very first moment. Digitally assisted rheumatism therapies from the patient's point of view is now what I'm going to talk about. The German Rheumatism League comprises 16 national and 3 member associations. We are the biggest general association, patient self-aid, with more than 300,000 members, over 1,100 working groups, more than 800 self-help group, approximately 10,000 volunteers as experts. My future vision is I'm affected by rheumatism. I want to share that. Only 5 minutes daily data entry routine in the morning and evening. This ensures the monitoring and the databases for a high-quality treatment, treat to target, that is, in the joint decision-making process with my physicians and treating physicians. We have a quality time when we sit face-to-face, opposite each other whenever necessary, and we can also communicate on digital channels. Smart wearables, that is, digital documentation systems and assisting technology support my wellness and disease management in a patient-centered way. Relevant information is intelligently tailored to my needs, and data sharing is aligned with my privacy preferences, and so on. This future for myself and for rheumatism also, not only for rheumatism but also for other chronic disease patients, maybe it's still 3 to 5 years away. I cannot even exchange emails with my rheumatologist with a coded email or arrange appointments, but nevertheless, I do my utmost, and I'm really inspired by the people I hear who are speaking about networked communication, so that this is the future that will be possible for my patients, and this will come a reality as quickly as possible. I was affected by rheumatism 25 years ago. I was treated according to the guidelines because I have a rather aggressive type of rheumatism. There was no sufficient medication or adequate medication for my type of rheumatism, so the class of medication was able to help me, but what we can see here will make a significant contribution, if it happens at a sufficient quality, will make it happen that there is a lot of avoidable suffering and load and of the pain will not happen anymore because we have different possibilities at hand, therapeutic possibilities. So you know it. What are the possibilities? We have at hand lifestyle apps, service apps, wearables, digital assistive technologies, e-prescription or subscription. We as a Rheumatism League and as stakeholder association, we ask ourselves, how can these teething troubles of these digital applications be cured as quickly as possible, and how can more quality, high quality and benefits be gained for patients, doctors and medical professionals? How can we get from the very beginning maximum user orientation and accessibility right from the start? And what role can self-help associations play in this process? There are 3 challenges. For instance, for digitally assisted rheumatism therapies, of course, we have the challenges that we need to define the goals and that we need to coordinate the actors. We need to establish who is in command and who distribute, or how are the roles distributed. How can we find a common level of communication? Given the multiplicity of stakeholders you see here on this list, if I take my chronic disease rheumatism as an example, then I want as many of those players listed here to network and to interact with each other and render their contributions so that I can manage my rheumatism together with my operators and with my HCPs in a better monitorable way, and thus to find a balance between my role as a patient and between all those financial holders of those services, because this bears opportunities that we do not currently have in our today's health care system, and that do not contribute to a well-balanced provision of health services. Because if you don't regulate and set common goals that orient certain values, then once again, this will be a solution that is driven by the market, that does not ensure the best quality of care for the patients. The next challenge, also for the digitally assisted rheumatoid arthritis therapies, for instance, the challenge of safety and digital health competence, how and by whom to establish. If you think about the vehicles of the last centuries, we took up on a new technology and we were full of inspiration and enthusiastic. And of course, there were dead horse and dead chicken on the streets. In road traffic, 3,900 people die every year, and nevertheless, nobody thinks seriously about questioning our traffic systems. The challenges are that we need to work on it, how digital solution that we will launch on the market can bring about and can create the required safety, and the digital health competence can grow in doctors and HCPs. And this very quickly. The next challenge, the selection, the choice we have. Out there, we see many digital healthcare solutions. And we, as a patient, do not know which will be the ones that really help us as patients, always based on evidence. If you insert as a search term rheumatism, you see a colorful selection with 200 or 300 hits. What appears is the app of the German Rheumatism League. That's the first choice, but many more also show up. So who helps us to make the right selection? And of course, I expect from my doctors and other HCPs that they help me exactly with this question, and that they tell me which of those 30 rheumatism apps could be the best ones or just the right ones for my specific rheumatic disease. And on top of that, the German healthcare system gives me reliable information so that I can do my own research based on that information and can search my array of little helpers in terms of apps and digital services. Where can patients find and rheumatologists find reliable information and recommendations when Dr. Google App Store and Play Store are obviously not the best choice? There are many directories of private persons, companies, and foundations, but there again we have the problem that the criteria are not eligible or are not suitable or they're not free of cost. Bertelsmann Foundation whitelist exists. It is comprehensive, and there's also the checklist for the use of health apps from the Patient Safety Action Alliance. But this hasn't been an answer to the existing question so far. The legal framework, maybe you wouldn't reflect so much on that. There is the Impaired Persons Directive in 2019 that was ratified. And if you read it through, if you thoroughly read it through this UN Convention on the Rights of Persons with Disabilities, then you know that there is a claim to digital health in healthcare, rehabilitation and care, and its central quality criteria include full participation and non-discrimination, high quality, timely, affordable, barrier-free, accessible, non-discriminatory implementation and accessibility of health innovations, data protection and freedom of expression, education of users and medical staff, and early systematic involvement of users in research and design processes, as in Article 4, subsection 3, and an access to adult education and lifelong learning. And the target group is all people with threatening disabilities, which is to be transformed in German law. And of course, in Germany, we have a diverse legislation, you all know it, but measured against these measures that postulate a full compensation of all impairments and provide enough resources in theory, given that we in our German legislation, starting from e-health law, and you know them all, we amount only to 10, the implementation is only 10 to 20% when it comes to the measurable claims. Here again, you have the chapters on research and development. I shall be happy to make this presentation available to you. Now let's talk about the data. I extracted the e-patient survey. It says that a doctor and his team are the most sought-after sources of information to explain DHA use, but educating users is a multi-professional and definitely multi-sectoral task. You ask them, who is to explain these apps to you? Somebody from my doctor's practice, and they say, my doctor, 30%, or 23% my health insurance, or somebody at my local pharmacy, 15%. But 30% say, I want to do this for myself. So you see the claim that there is for information. So the medical system should be empowered so that they can deal with these new apps and applications and new systems. A little study excursion into my rheumatology world, digital rheumatology in the era of COVID-19, result of a national patient and physician survey. That was a survey by Kanda and others. R&B Open 2021. It was about the impact of COVID-19 on rheumatic patients and rheumatologists, usage preferences and perception of digital health applications. It was a web-based national survey enrolling almost 300 patients, 299 and 129 rheumatologists. And we were involved in all the stages of this survey. It yielded 3 or 4 findings. DHA is rated as beneficial for health and disease management. So that those were the answers. I believe using digital health applications is useful for managing my disease. You also see here on the next slide the ambiguous attitude of patients. They say digitization has different effects on the doctor-patient relationship. 30% of patients and rheumatologists state both positive and negative effects. Approximately 1/3 or 1/4 rates it to be positive. And that's more than negative ratings. So you see, where are we headed and how do we communicate that, meaning the added value and the potential challenges. So we have to do a lot of joint work on it. If you look at what is used already, what rheumatism patients use, you see that there is widespread use of digital information, regardless of the quality, and also what's used is symptom checkers, and you see that there is an increased intention to use video consultation, digital therapy, digital questionnaires, and digital diary, and a rather moderate intent to use it, to use home blood draw. So those things are underway and keep developing themselves. Here, as in many other surveys, we see multiple benefits of digital health applications. Location independence and time independence were mentioned most often, with shares of 70 to 80%. Detailed documentation, cost saving with 30 to 40%, and more flexibility also in the area or from the perspective of the rheumatologists also seem to be beneficial. But what you also see, and that's nothing new, that there are multiple barriers to the use of DHA. By far the most frequently quoted by patients are lack of information and ease of use. So patients, almost 60% of the patients say that they receive too little information. Almost 30% of the rheumatologists say it. When it comes to evidence, that rheumatologists say that by more than 20% that there is the poor quality of the current apps, and more than 40% said it's not easy to use. And this is probably underrated. Also, the accessibility is not so good. So there are many obstacles that we hopefully will overcome as quickly as possible. If we look at the market, I retrieved those data this morning. When it comes to DIGA, we see the first applications, digital health applications, multiple sclerosis, anxiety disorders. Those are 20 or 30 applications that are out on the market. Only 5 of them, however, are taken up in the inventory durably. The others are under trial. So far, only something for arthrosis has made it. If you look at the app for arthrosis, that you see immediately there are many exceptions. Diseases of the knee, prostheses for the knee are not allowed, and the arthrosis app is not accessible at all for visually or hearing impaired persons. They are excluded from the usage. So you would ask yourself the question, what about the usability of those apps that are basically funded by the whole society? A little criticism on the DIGA class of apps. Those apps are not with a compulsory participation of patients, unless contrary to the digital medication. So the foreseeable consequence of that is deficits in user orientation. There are many, and we are currently working on the improvement of the system. If you look at the total picture, however, you can only hope that digitally supported rheumatism therapies will be better and faster in a well-coordinated team, and that they will be promoted so that we reach the goal faster, so that the vision of a networked disease monitoring with various therapeutic options will become a reality and will be free of obstacles and will be accessible in a patient-oriented quality. We, as a Rheumatism League, we have a project patient partner with whom we actually contribute to the improvement So we have trained patient partners, 166, and research projects we carry out, and also digital projects. And these activities we will reinforce in the future. And if I come to now coming to my conclusions, we as Rheumatism League wish for the creation of more digital health competence of all stakeholders, as well as a reliable information base at a national level. We would like to ensure the structural participation of patient representatives and their associations in research and development from the outset. We would like to obtain more also patient-generated data with regard to rheumatism, therapies and care situation, so that we can and we want them to be evaluated in participatory research. We would like to see the creation of more and different monitoring and other digital devices. Currently, there are only 2 apps. We would like to see the interoperability improved. Why do I have to wait 3 years until I can actually populate my electronic patient record with my digital apps? Of course, also ensure patient autonomy, data protection and data security. And then we would like to put more model projects into practice and scale them up. And we would like to ensure digital inclusion in all areas. And of course, we wish in the next legislation period, we'd like to see the integration of a national digital health strategies, because if we may believe what's being said in politics, we seem to get there. Thank you very much for your attention. And here you can see my contact details. I'll be happy to receive your emails. Thank you, Ms. Ben-Suk. Good that you're here. I would like to welcome my panel. We have one person less. Mr. Taramendieta, unfortunately, will not join us because the connection wasn't that good so that we could keep it up. But it's good. Anyway, we have a colorful bunch of people. We have made we've seen the big picture from evidence-based medicine from European to regional projects. And it's all very colorful. What reunites you is the will to improve patient care, to improve communication, and to see also the economic factor when something is improved. Of course, this needs to happen evidence-based and must correspond to a European standard. Very often people like to put an emphasis on saying that we still have time to shape the healthcare provision before the big American players or Chinese players do it. I have the feeling in such panel discussions that everyone wants the same, and you know that communication and standards improve many things. Nevertheless, there are hurdles in daily life that apparently are that so massive that it still is difficult. Now I would like to start with Ms. Ben-Suk. You have addressed some of the challenges. Which offers, however, would you wish for precisely in your daily life as a patient with a chronic disease? And who should drive them? Is that something that you hope for the politicians to arrange, or is that a societal claim, a claim social-political, or who should actually trigger those changes? Politics will make the change prevail, but driven, that's the exciting question, and this is where my input is pointing at. This development is driven by the most various actors. If you look at who was prevailing so far or what the sustainable quality is, of course, the representation of interests of the stakeholders, but also doctors and also medical professions that should put those quality questions, that should integrate those quality questions much more in their processes. So this is why I don't find it difficult if economic organizations, pharmaceutical companies, startups also get good money for good work. That's not the topic, but But the motor should be more those should be the motor who actually render the work on each and every patient. If you ask yourself, what does it take for us to do that? You get to the point very quickly that that the patient representations, patient advocacy groups, but also patient self-help groups, that they need to be supported structurally for their task, because we do that on top of our other political tasks, analogous, improve analogous accessibility in the free world and help renew KR concepts, and to see to it that in medical approvals that everything's going the right way. So we can hardly find honorary work examples where those tasks of the GBH and the country organizations also take on this task. And now the digital health sector or healthcare sector. And in Germany, according to what I estimate, we would need 250 qualified patient advocacy representatives. We don't have them. I know around 20, not 250, in order to further drive this perspective. What you would need just the same at the level of the doctors level and at the doctors representation levels. There is a working group of young doctors in rheumatology that drives it, but we would need people that are willing to invest even more time and energy into those topics, to be the drivers and the advocates of such topics. And the professional people, where do they get the resources? And the system does not have an answer.
We heard what Mrs. Benzog described is a fact, especially on the German level. What about the EU level? Can you think of a country where patients have a stronger voice? I think overall there is a cultural change we're currently experiencing. I think that the cultural change, and this is an extraordinarily important point for us, the cultural change going on in projects already started 4 or 5 years ago. There's always co-design and co-creation, and co-design and co-creation as project principles, not driven by a technology push, but driven by the need involving citizens and patients, have become a culture that one country finds it less difficult than another. Well, I wouldn't want to decide, but what I can see is that in many countries this has gradually become part of the project endeavors. This is also the case with the projects we've seen now that we've done with our WTH in Aachen, co-design and co-creation. I can only endorse what was said. Of course, the participants are scarce in this process, but this is a process, co-design and co-creation, that needs resources in terms of participants. And what we do from the European side is that we insist that this is covered in the working packages to ensure that communication and that this development has a substance and is anchored. We actually ran a major survey among patients that actually turned out to be a lot bigger than we originally thought. Within 2 weeks, 1,400 patients went through our survey, and we wanted to know whether they have their own ideas about what digital solutions could do for them. And we found that, in fact, many have an idea, but they lack a network to get such a solution going. With a jury and an advisory board, we actually initiated 5 solutions projects that are now in the pilot stage. And we felt that collecting this expertise is a great benefit for all parties involved. The way we do it with gendering, you always have to think of all parts of the population, especially those for whom you want to develop something. Mrs. Benzuk said something very impressive. She said that many solutions aren't evidence-based. This must hurt you, Mrs. Benzuk. How do you see this? Is evidence-based health research actually gaining grip? You go online and you get everything, but would you want to see structures that promote what you have researched so far? Yes, of course, of course. As a very brief answer, I think that we're still in the early stages of what we've established in our systems. We start with medical students from day one. Problem-oriented learning. They have to question their sources that they use for solving a patient case. So we're really trying to already embed this in the medical training for future doctors. But it never stops. How evidence-based findings can be obtained. So there's regular training and further training for our doctors. I often lecture on where do I find quality literature and how do I distinguish good from bad literature. In my teaching, I try to bring it home to my students that what they learn about EVM is nothing abstract, but they need it every single day for the daily practice. I can experience change. I have the feeling that more and more people ask themselves about this. But returning to my presentation and COVID-19 therapies, I think there's a lot of room for improvement regarding beneficial and less beneficial therapies for COVID-19. I don't want to mention what does not help against COVID-19. We've seen that people are easily misled because a certain person of a certain authority recommends a something or a measure, and citizens should actually be trained, all of them, to distinguish reliable sources from non-reliable sources. Not only citizens or doctors, but also policymakers who stand on a stage and issue recommendations on therapies. And if it's not evidence-based, it's not very helpful. We discussed this beforehand and said digital medicine not only enters many areas, but we also said how many areas influence digital medicine. You explained this very impressively with your network. And health competence, for instance, it's being said time and again that this must be taught in primary school. I keep telling my son, you need more than one source. My mom did not tell me that. I think we're on the right track. Listening to Mrs. Benzuk, Professor Farsen, and hearing that patients are not often asked, do you then think, no, we had a focus on this, or would this be a focus for your next advisory board meeting? Yeah, both. We are aware. Here in the region, there is a wonderful project which began as a startup. It's about the digital use of objects for older patients. The founder had a grandma saying, well, I want to help this woman. So we do market this and still use it to raise awareness because, to my mind, this is the pivotal point. We have to be aware of the addressees and what's in it for the recipients. I am the CEO of a regional association that has a political parliament, and in all of our project ideas, we are actually recommended by the local politicians time and again, always focus on patient benefits. And this is an important reminder, I think, because very often you're so enthusiastic. I have a 92-year-old father who has a background and loves digital elements, but sooner or later you come up against limits, and this is why it is important to actually keep track of this in everything we do. There are these examples from the Netherlands. Science, policymakers, business, and citizens. There are certain target groups that these products are made for. But even for business reasons, this makes sense because, after all, the companies want to be commercially successful, and this will only be the case if people really use them. I think we are all aware of many, many items that do not really work well from our households or from our daily environment, and this is why it is extremely important in the health segment. Mrs. Benzuk, you wanted to come in. Yes, when you actually mentioned this dogma, this paradigm, the market will sort it out. This only works to a certain extent in a market that is regulated by supply or care structures. The beautiful new digas popping up, these are the certified ones that can be reimbursed. If my thesis is right, that 80% of the DIGAs fail because patients do not want to participate, and the benefit is down to 70%, and the DIGAs are not really great, then there will not actually be a high quality or patient benefit in using these DIGAs. Only if we have binding standards of good practice for patient involvement in these digital innovations that are reimbursable, you will have this built-in quality assurance for drug or technical device research. What I would like to see as the Rheumatism League and as a self-help group, we are asked about projects. We have a great project. Don't you have any patients that can help us with our development? This is not a systematic approach. You have to establish a standard for good patient involvement, established once. And in the countries or in the lands or at the digital hubs, there are you can actually connect with cooperation models and actually find patients as a panel to involve, so that this is not simply coincidentally and somebody actually uses his or her granddad or grandma. Although most of the big innovations have all emerged from a personal major need, where do you see the responsibility of the self-help groups in this scenario? Because there are always two sides to this. You are, of course, pretty well known, and you will know more people than I do. You have to actively search very often, and you have to get more structured or organized? Where's your responsibility? Well, I think I know of many startups here in Berlin, for instance. Over the first 2 or 3 years, they are really working so hard, developing their products, finding rooms, finding people, but patient involvement from the outset and talking to the right people and the right amounts of people and get the feedback going. This has not been implemented in a systematic fashion, like the diabetes response groups, where the endpoints have been defined by patients, not only the HB value, but also the intervals at which tests are to be carried out, and how exactly the feedback process is organized for physicians. This decides about the practical benefit of the NEP. If you involve patients right from the outset, as we did with the Rheumatism League, then the product will be 30 to 40% better, the outcome. And of course, you can also launch a marketable product without patients, but it does not have this quality. And against the backdrop of sustainability, this is an opportunity we should use. And that you have to contact or think in terms of self-help groups is not bad. These are resources in the analog patient representation structures, in the GBA, for instance, in these subcommittees we have there. We need to qualify or build the skills of people who, in an honorary capacity, act as patient representatives. And this would be a fantastic opportunity for self-help groups to activate other people who are interested in this. I'm not saying old or young. I'm looking at various generations here. I would love to see an armada of senior citizens from Germany who really judge digital little gadgets for senior citizens. This is a phenomenon that not only startups experience. I talked to the director of a fantastic hospital, and he had developed a fantastic product, and it went through the wards, and everybody said, we don't have a problem with this solution. I'm sorry, we can't use it. At which point can we enable as many people as possible to opt for the digital approach? I think we're discussing the right points here, but it's always difficult because your own perspective is, of course, always a very strong view. If you say patient involvement is the only thing that enables the right solution, then it's getting difficult. Or contrary to what you said, have the right solution for no problem. Understanding is the key. Understanding that co-design and co-creation processes require time, understanding, and patience to see what the actual needs are from the patient's view, but also from the treatment's perspective. If you design perfectly for the patient, but if the physician and the nursing staff can't handle the solution, then you won't experience proper care as a patient. So we need to reconcile these two things. And we have to reconcile these two views and these people and create some common understanding. This is the key to the solution. And on diabetes again, we have incredibly elaborate but seen some highly productive projects on a European level, and I could actually demonstrate you some solutions. Maybe I'll do this next year if we're lucky enough to meet again in this group. But what we do see is when you get the solution, obtain it involving the various different different views. And if the physician says, well, I'll have a look here, 1C sequence, or then you can reconcile elements so that everybody can use it and is happy using it. And then we have a sustainable solution. The market distortion created by the demand, created by functionalities and reimbursement schemes, we view this to be extremely difficult. And from the European perspective, let me say each country is different, which does not improve matters. So what we would push on the market for innovation purposes is not necessarily loved in Germany, and in the next country it will probably be anything you would want to see, and it does not have anything to do with the culture, but only with the functionalities of reimbursement schemes and acceptance. I would like to see co-design and co-creation being instilled with life, together with the contributions of nursing staff, health professionals, curing staff, and first and foremost, those who want to use the technology, and that is the patients. Ms. Spenstrom, you are basically on a wave of success with one of the NUM projects. So you found a basis, you know where to go, you have the infrastructure ready, probably not everywhere. Talking about networking and adopting, where do you see the biggest problems and challenges for a coordinated patient care in your area, for instance? Is this the infrastructure, or is it communication, or is it trust? What you said? Or where's your way? You asked me about care and research. This is two completely different things. It would be wonderful if research could be done while care is being provided. Yeah, even during the COVID times, we had excellent examples with the study carried out with pregnant COVID patients in Aachen in cooperation with Erlangen. There are many, many examples where this has already worked pretty well. But it is not part of our standard repertoire yet. What we've seen over the past 2 years, I have learned that we have a pragmatic, low-threshold approach that we require so that we can move as many people as possible to take part in such a project. If you actually have to register cumbersomely, answer 17 emails, or probably receive a code by surface mail, it simply won't work out. This is not realistic. A realistic situation where there's not even Wi-Fi on all of the wards, and where our participants can dial in for a telemedicine network. This is my answer. I think this must be our intention, to make it easily accessible and low threshold, and then we stand the biggest chance to establish this across the board. Professor Fassen, your major project in Düren, were you afraid, or were you initially afraid doing it that it might turn into the German angst syndrome, where you try to talk a lot about it and to find out 15 years later that it is not accepted? And that it never gets out of the discussion stages, and although everybody agrees that it makes sense, but you don't do it all the same. So what is the infrastructure you need for this? I think this is a basic problem of Germans when they tackle new things. There is always a group of innovative people who want to get going, and then you have a far bigger group who has this inertia. And we are lucky because we're in a border region, and you just have to look to the Netherlands, how courageous they often are in these things. And I think the most important thing is, and also from my other professional experience, is we have to build trust and confidence. This takes so much time. And this is also a problem we faced with COVID, because we lack the personal encounters. And I think you need about 2 to 3 years as a lead time for such a project where you actually build the trust among project partners. If they all share the same aim and know they can trust each other, then this works out quite quickly. But the decisive task is to take the critical voices seriously. And this is so cumbersome. It is so stressful. And you have to be very optimistic to try it time and again. But this will be the key. If we fail to do this, to actually involve the people who have a critical view, this is also in a way that is important, and to actually share those valuable insights with them, then it won't work out. Such projects do exist. You talk, but you never start doing anything. And this is why I always say, let's start with the small and simple things that you can then demonstrate as a success, a showcase, and then even those who are very critical conclude, yeah, why not have a go? This is what I experience every single day in regional development. So you require a lot of time, and don't be upset if things don't work out immediately. Always work towards the aim. And times it's a stony way and it's a long-winded road. What you just said in passing, at times it does not work out. What I often lack in Germany, especially in the health industry, is this mistake culture or error or fuck-up minds where somebody says or tells or shares how he or she really fucked something up and nevertheless arrived at the result. How do you actually include or embed such fuck-ups in your process? Well, on the one hand, this is a cultural issue, that you allow people to fuck up. You sense this with employees. If you don't tell them, oh, no problem, what did you learn? What's the lesson learned? Then it works out. And then you have to do this on a regional scale. You can't avoid it. Only if you don't do anything, you can avoid making mistakes. Don't overestimate it. It is always important to organize a group in such a manner that the group learns from mistakes they've made. And I think this is what we can learn from other countries. Forget about the German mentality. Mrs. Benzog, a wonderful opportunity, the COVID pandemic. And this was a great idea. Under non-pandemic conditions, it would have been unthinkable to actually initiate this virtual hospital to get this really going. And there was a lot of emergency and misery, and they simply got going. Of course, there are improvements possible through the experts. We were able to support the local COVID-19 therapy. And I would like to see that this stays around to a certain extent.
So this is also a task for the European Commission and the member states. To what extent do they take account of the error culture? I would say they don't have such a negative image. It's part of the program. From the German perspective, maybe that's actually rated in a very negative way. that that they say there is an over-engineering, but an over-engineering can be very valuable because you need this very contribution because you cooperate with others who have a different focus or have their focus on different things. If you see how easily it is to find a balance in which you can compensate for the over-engineering, maybe with a pragmatic approach, but something we need to use. It could be the Netherlands, but it doesn't have to be the Netherlands. It works for any other country. With improvisation is what counts. This is not what he said, but no, quite the contrary. I believe that the tendency to build sustainably is a good trade and to build for eternity. And if others are more there to compensate and level out, and we learn that excellently from other European projects. I have seen that numerous times, and you wouldn't believe how quickly other stakeholders jump on the train, scientists and others. And I think for the innovation centers and the hubs too, it is very important that when they work in the networking with other hubs and have other accesses, they can find obvious approaches for solutions and can test them for other markets. But it's not only about markets, but also for other circumstances, for other patients, other treatment and care environment conditions. And I think this is very enriching. What we always try is to make the optimal development in the local, in the micro, in surroundings. But the development that you dismiss here because it simply cannot be done because something is not approved would be a perfect solution elsewhere. And I think we have to be more courageous. And this error culture, to register errors and to learn from errors, at least in these corporations, this is something that develops when you work together and in the work between different settings and company cultures. This is probably something that you have realized in the last 21 months. Yeah. Yes, absolutely. And also the fact that it is not always the goal to reach 100% or to do it 100% perfectly. And especially in healthcare to a patient group. That was so strange and to us, you need to tell each other what it is that doesn't work, and you have to raise your voice at an international level, what works well, what doesn't work well, so that the other locations can benefit from it. When it comes to communication and knowledge transfer, we have learned a great deal in the last 21 months. There were doctor symposiums from America, from Europe. They would gather with 20,000 people in this one meeting where everyone learned from another, from each other, and nobody rolled their eyes, and everyone could ask their questions. And that has actually benefited, the international research communities has benefited greatly from it, because just as much as we because we had to implement it in our normal daily life. Miss Fasen, there is this stupid bon mot of Dorothea Bär. You don't need 5G everywhere, in every little corner. I think this is also outdated now. Which infrastructure projects would you wish for? Not only, especially for your Ilona project, but in general at a pan-European level. The digital provision with 5G is surely a central issue, because the technologies that will develop in the future, also quantum and supercomputing, they will enable totally different things if you think 10 years ahead. But in order to see that, and this is what I see in Germany, what I perceive to be very difficult in Germany, when you drive through certain regions in Aachen, you know you can't phone because it just can't be done, no connection. no internet service. And other countries, the Baltic states were ahead of us 10 years ago. And I think this is a central task of politics to make the funds available. And this is something that they take on in the Rhenish Main area. If you want to make that future viable, this is a really important prerequisite. You have to explore mobility. You have to transport people from A to Z. This is really important. And you have to make it happen that we have a digital infrastructure, because otherwise we can develop the weirdest things. If I cannot apply them in a rural area, then it is of no use. And it will not patients will not benefit from it. And I think this is why I think this is the basic prerequisite. But I am of good hope that at least in the Rhenish Main area we will be able to launch it, because we stand good opportunities because of the money we have available that allows us to tackle these things. But I think we need it everywhere in Germany. And we can only hope for politics so that they realize this and speed up a little bit. In the European Union, the project you have shown us, it was very much content-driven and had the same assumptions as a foundation. At which level do you see the infrastructure project? Are they thought to be self-understood, or is that a problematic zone, something like the forests around Aachen where you don't have 5G connection? You mean as for the infrastructure, the accessibility, reachability? If you think about network expansion, that it will be shown at a country member level. So the regions have to say, this is our need, and here's the prioritization in which things are tackled. You will only reach the Aachen forest when the city and the land and the nation prioritize it. And it would be worse if somebody else would be the competent party to decide that. Yeah, but sometimes it helps. Yeah, and we perceive it and we discuss it and it's politically evident, but no, it's not considered to be as an evidence or as a natural thing. But of course the programs depend upon the interaction, and I showed it in some of my previous slides. The digital program is networking with the research program, with the infrastructure program, RF, Recover and Resilience funds. You can only do it jointly by the programs intertwining, and this will be the prerequisites for us to get things going. And of course, it's obvious we can have great digital tools. If we don't have the network for it, then we are left behind. But this begins with the obligation of the network providers to give access to individual parties, and this is what we find in our contracts. Thank you very much. I would like to thank this round. I wish you a lot of success to all four of you in your endeavors and projects. And I hope you will also be able to Health and Innovation Hub. I hope you will be able to roll it out large scale. And now I'm looking forward to next year to see how your things go on. We move on with a little summary. I can see Mr. Marx. I don't have a mask, but I'm moving here through the studio. So I'm undulating, so to speak. Was it the wrong side? No, it was okay. So we have heard many exciting things the whole morning, throughout the day, before we move on with the Digital Health Award. We would like to recapture here. The session was under the motto, what does Europe need? So what is your learning? What do you take home from the projects that were shown to you? What I take home is on the one hand, that this could be seen very beautifully in the last session, that this is something that has been like that the whole time. We had an incredible number, especially in Europe and also in North Rhine-Westphalia. We had an incredible number of good and successfully done projects which have shown something where the benefits of a better healthcare provisions are and which have yielded real outcomes for patients. And we had the one night or just one day, one hit wonder phenomena. I heard from many prominent speakers, top-flight speakers, that man important political functions, that we are on a path which, as I said in my welcome speech, which has been accelerated because of Corona. As a pandemic response, that we now take these important steps towards structured systems and funded projects. But many of those projects, maybe not all of them, that could be established now as the new standard. And we hope that at country level, at Länder level, and at national level, and I'm very grateful to Dr. Klein on a personal note that despite his full agenda, he has found his way from Luxembourg, from DG Connect to Aachen, because at the end of the day, we will be successful if we do it at a European level with a European interaction. And we will not be able to do it alone in a national state. You can't do it successfully. It's only in these interconnection, in those big alliances, you can manage to do it. You can also act locally and in small associations, which is basically the prerequisites that the various regions and that we can connect them to Europe. And another important point, and maybe that wasn't addressed enough in detail or in the past, we did not consider the view of patients, the perspective of the patients. We have to listen to them and we have to take them on board, and just as much as thanks to cooperation processes, like in our last recent EU projects. So it's no use if we always establish new projects, new structures in order to facilitate digitalization, but we also need to see to it that the people that work in those structures and with those products, that they know why they are doing that and why there is an added effort which can, however, amount into an added value. So it means a lot of expenditure and effort. And we have seen it in telemedicine. Initially, it was always a bit more of an effort, and then after some time, everyone was very happy with it, because they could see the effect for their own work, for the work of the team, and especially for the benefit of the patient. And I would also like to underline, and you are just the greatest examples for it. Of course, development works if it is linked to persons that commit themselves to the cause 24/7. Or Ms. Fasten, who actually commits for this project very strongly. You realize that a lot is happening and a lot can be achieved, although previously it was not describable. And the error culture and the discussion culture, and if you manage to interlink it, then you can forge structures in which you pursue a goal jointly. And that's the goal of us all, an improved patient healthcare, not only in Germany and not just around Aachen, but at a European level. So we should be able to do it, shouldn't we? Absolutely. As an intensive care clinician, I'm always confident, also in the fourth wave of the Corona pandemic. I believe it's important that there are people who have an idea of where they want to go. And I've learned, especially also in our large innovation park project, many people were involved in it, many outpatient practices and hospitals, people who have never before been involved in a project. So we managed to make them enthusiastic, and now they carry on independently. And I will never forget it. There was one colleague from one of the houses who said, see to it that you can get it done, that we can go on with it. We want that, we need that. That's the new standard now. And I think that's exactly the way to pursue. And another thing I have learned is you can do that on the side and for free. These progresses, the integration of new processes and structures, such new networks really means a lot of work, and it takes resources, time and staff, man-hours. You cannot not consider this to be an additional task who has a full workload anyway. So it's a known form of innovation, and this is why I am thrilled that the country government of North Rhine-Westphalia has understood it and has implemented it, because within 7 days, as a pandemic answer, we have built the precursor of the virtual hospital, where some people worked day and night for it to function, and they could only do it thanks to their previous experiences. And they said you do it as Aachen and Münster, but they have now they have appointed a managing director. They have now 14 people working there, and they do exactly what I've just said. They take care, and not only on an honorary basis after they're off duty. And those are important points, and this is something we need to establish in many locations in Germany and Europe. Those who move on, who are the spearhead of the development, have to lead the way and have to convince the others, because it's not just about ensuring healthcare provision. It's about improving it. The example with the democratization, that's a central point of it. And what's really good, and it doesn't mean that every little hospital needs to be switched off. And everyone has to just go to the university clinics. Also here in open spaces, we need to keep up and preserve the healthcare provision. And when it's necessary for an intervention or for a surgery, you can transfer a patient to the university clinic, but it has to be, you have to be able to do it also in rural areas. And that this is not a professor's talk, an academia talk. We can see we have more than 75% transfer rate, and it's 11%. Because of the telemedical assistance, you can actually give healthcare to people regionally. And against the backdrop of the demographic change and against the backdrop of the structural change, it is of course true that healthcare provision needs to happen on site, and it needs to be de-escalated, and only then has it to move into the next bigger city. So we need to ensure healthcare, but we don't have to turn everything head over heels, but not just take expertise to somewhere else, but also accept it from outside. And this was something that Ms. Benstem has illustrated very nicely, how we learned from each other and how fruitful it was then, and how knowledge was transported to people studying, so that they know from the very beginning that something has changed in medicine and that you need to talk more to each other. Yes, exactly, and there's really urgent need for action. I always tell my students here in Aachen, you are actually trained better than I was trained. Yeah, they're much more practice-oriented. Yeah, but they still have to carry your bag. Yeah, they still have to. Haha. No, but the point is, these additional skills and qualifications in order that are necessary so that you can roll out and scale up the services. Here we need to change our curricula. We need to offer more so that you can maybe obtain your master graduate degree so that we can actually live up to our promises, so that it does not only come from some hospital centers, but that it is rolled out at a large scale. This will bring about a structural change that we still don't see in Germany. And it's especially this European thought that I like, especially if you train well people, then they move out and they spread out all over Europe. But we also want to have the expertise, the brain from all other European countries. And quite automatically, this aspect of understanding each other is also what matters and is emphasized very much. I hope that because of this we can make a contribution so that we do no longer separate each other, but on the contrary, that we collaborate and communicate so that you can establish a better life. You need different curriculums because technology will actually take over much more. The previous speaker said that AI is on the rise. It's more a hype nowadays, but nevertheless, the technical development makes it that the doctor can take more time for the patient maybe and needs different skills than the skills you had to have. Maybe more soft skills will be taught in the university. And it's just not just a hype. Those hematologists who give healthcare for blood cancer diseases, they have made much more progress in precision and robot-assisted medicine, but also in telemedication we have made progress by means of the data that are available to us, and we can actually make a diagnostics at a more early stage so that we can prevent diseases and not just treat the diseases once they have onset. I think in Aachen, Industry 4.0, we made it to bring this into industrial manufacturing. We don't have to do it all ourselves. We can communicate a lot with each other and take the assets along. I'm rather confident. You might have notes. I think it's 2021 November, and I think in 2030 in November we will see big leaps, not just steps. And we will use the times in between and do our utmost so that we can make it to fully exploit the potential we have in our hands so that we can ensure a better healthcare provision. You stay with me, bear with me for a little bit. I will stay with you at any rate, and at 4 o'clock we'll talk, and then we'll check out the pitches and the startups with their innovative solutions for the healthcare market, and we will award the Digital Health Award. We resume at 4 p.m. Looking forward to it.
I'm really happy that you have returned to your screens after the exciting morning and early afternoon, where we heard about lots of European projects in terms of communication and improvements for patient care. We now come to the secret main act, and this is the presentation of the Digital Health Award. Last year, it celebrated its premiere at the Digital Health Now as well. And this morning, we heard Minister Pinkwart, who acts as a patron for this. The ZTG and IT Health Germany are the donors. And over the past 2 years, they have served as fantastic partners, contributing lots of competence and expertise and added value for contestants. And this is why I'm particularly happy to have Mattis Palm with me as a co-presenter. Hello, Mattis. Good to see you. Sound problems are gone. Can you hear me? Can you hear me? Yes, I can hear you very well, Claudia. I'm happy to be able to present the award winners and to actually co-present with you. I'm not so happy with the sound quality. I hope that the stream is heard a little better. Maybe you should definitely use a headset, not pods, but a microphone, a headset with a microphone. But let me introduce you first. Since August 2020, you have been part of the business creation team at IT Health Germany, the Health Innovation Hub, but you have started lots of projects, and you are a very constructive partner, entertaining partner that we got to know in the meantime. IT Health Germany supports in Germany and Austria and Switzerland. Mattis Palm is, of course, thrilled with the possibilities that digital technology holds in the healthcare sector. And you talked about lifestyle changes, possibilities for telemedicine, and we're in the right place, considering the 10 teams, the 10 contestants. And we will kick off with these very quickly. One organizational housekeeping note. You should find a link under the live stream, and this is for polling purposes. We will first have all 10 teams showcase the 10 contestants, and then you will be given time to vote on all of the 10 teams. We opted against actually doing this for each project individually. We're looking forward to your input, and now we're looking forward to the first solution, because we selected or shortlisted 10 of 41 contestants. We will be watching one short video, the pitch, and then have the possibility to pass on your questions. And if not, you can also rely on Mattis and myself regarding some critical clarification questions. And we will kick off with the platform Deep Eye Vision. And this is a local Ladi. This company comes from Aachen. The first video roll.
By 2040, up to 26 million Europeans will suffer from vision loss due to age-related macular degeneration, short AMD. This retinal disease alone accounts for 50% of blindness. Today, patients are treated according to defined, standardized therapy regimes. Unfortunately, the personal cause of the disease cannot yet be taken into account, leading to most therapies being aborted after some time and real-world outcomes far from those of clinical studies. We at DeepEye empower ophthalmologists with a digital therapy planning assistant. Based on thousands of retinal scans, our AI has learned to predict how late-stage AMD will develop, with immediate, delayed, or no treatment. This means we can propose an individual treatment for each patient to the ophthalmologist. The improved outcomes will be analyzed as well and serve as valuable feedback for improving drug targeting and development. Our team consists of the Eye Clinic St. Franciscus Münster with 150 employees, including 5 professors, the Westphalia Data Lab with 60 eye experts, our CDO Radko, and myself, Manuel, CEO and digital health entrepreneur. Together we are pursuing our vision to prevent age-related blindness.
Okay, wir haben vorher vereinbart, dass nicht so schnell redet.
Okay, we agreed that he would not speak so fast. I'm happy to have Manuel Opitz with me. He's the CIO of Deep Eye Medical GmbH, and he will answer questions or actually allow us to clarify matters. How do you actually establish a Deep Eye Medical platform not being an ophthalmologist? Well, two factors played a role. On the one hand, I established contact with ophthalmologists through friends in Münster who said, well, they've gone through 3 years of research, they want to do a spin-off, can't you support them? This was the one way, a very practical approach. And then there was a personal aspect in my family. This eye degeneration, macular degeneration is very prevalent, 3 cases, and this is why I had the personal this is the age-related macular degeneration. What is the classification you're striving for with your Deep Eye platform? Our software supports physicians in not only diagnosing patients with this, but also in their decisions how and when to treat patients. There are certain risks associated when you actually recommend things too early or too late. It wouldn't be optimal, and this is why this is a risk product class 2 and corresponds to the European medical device order. So this is a decision supporting tool. And for doctors, and what is your payment model? Well, doctors will pay for us and pay per use, or what do you expect? There are 2 versions, both. We started with the pay per use model, but we can also talk about an annual license, especially for bigger centers. This is probably easier, but the aim is to not have the system at the expense of the doctors, but make it part of the reimbursement system. And we talked to private insurers already, and the results were very positive. A brief answer, please, to my last question. How smart is this platform? How fast does it learn from cases? It does not directly learn from the cases. Based on many, many cases, thousands of cases from the past, we have taught the system to look ahead in time and forecast the further development. So based on the data available to the physicians, we can actually produce a tailor-made diagnosis. So we actually make the platform that the doctor has a smart one. So let's see how smart. Well, Mathis, it's your turn now with part 2.
Super, Manuel. Vielen Dank.
Well, thank you very much, Manuel. You said that you're out of the research phase. Yes, of course. Before we do not official approval, we cannot be integrated in the clinical routine. But next year, we will go through a major clinical evaluation with studies, and we're allowed to do that. So we're working with the San Francisco's Eye Center in Münster very closely, but also work with pharmaceutical companies in order to cover the widest possible spectrum of patients. Okay, thank you very much. Thank you. These were your 5 minutes. Mathis. Well, and the next startup we will be introduced is Kids Speech Lab from Dublin, Ireland. Please welcome Shauna Darcy on the screen.
Hi, my name is Shauna Darcy. I'm the founder and CEO of Kids Speech Labs. We're addressing one of the biggest unmet needs in early childhood development, speech and language therapy. With an increased demand occurring across Europe, children are regularly waiting up to a year after a concern has been raised about speech and language development. We're building remote screening and intervention tools that can move the early stages of managing this developmental phase out of the therapist office and into homes and schools, with the goal of reducing the number of children who ultimately need formal speech and language therapy. We have good traction to date with pilots both in the UK and Ireland, and over 100 children have been on our platform over the last 3 months. We have paid pilots planned for 2022 and are excited about the growth in partnerships that we are experiencing right now. EIT Health has been a great support to Kids Speech Labs, and we look forward to further participation in EIT Health events. Thank you very much.
So, eigentlich sollten wir jetzt Shona
We should have Shauna live now. Hi, Shauna. How are
Happy
you?
to have you on the stage.
Good, thank you.
A warm welcome to the Digital Health Award. May I ask, can you outline what was the rationale behind you developing the Kids Speech Lab?
Sure. So my background is actually in speech recognition technology, and I've been working in digital health for the past 15 years, with a real focus on the challenges associated with bringing technology into patients' lives and how you encourage engagement. And this is an area that's been largely left out of the digital transformation we've seen across healthcare. So it's a particularly challenging one. And I found that through speaking to all the stakeholders, that also the parents' experience was being left out of how solutions were being built. So I really felt I could bring my experience together to develop some innovative solutions to address the needs of all stakeholders.
That's great. So you have addressed a lack of uptake in digital technology in the treatment of children's speech and language issues. How have you experienced the willingness of children, their parents, but also doctors and carers in using these digital platforms?
So the take-up from parents has been very good, particularly ones who've been actually sitting on waiting lists for a long period of time. And obviously, with a more acute need becomes a more acute willingness to accept anything new. The response from parents has been phenomenal when we speak to them. The engagement with the therapists is taking much longer, and this is probably one of our biggest challenges. But we know that we can, and that's why originally this was going to be a fully automated diagnostic platform, but the community isn't ready for that. So right now we're really building that framework of communication between the therapist and the parents at home, and even teachers, to show the power of digital health within this space. And then we'll reintroduce the automation piece once we have them on board.
Okay, so I suppose you're also developing your business model around that. Can you elaborate a bit on that, please?
Sure. So we are a software platform, and our goal is to support the healthcare systems to meet the increased demand for their services. So we're not providing speech and language therapy. We're not just trying to deliver a teletherapy platform. What we want to do is bring in a new component of the care pathway that releases efficiencies that they haven't really known were available to them, and allow, say, the national healthcare providers, because screening works at a population level, and that's our goal, is to be able to provide early screening, early intervention at a large scale to have the largest impact. And that's why we are working with the highest levels in Ireland in our healthcare system here, which is the HSC. So we have relationships with the Minister for Disabilities, the digital transformation team, and we're looking at now different countries, the UK, and obviously through EIT Health, we're trying to see where we can find applications within Europe as well.
Okay, thank you very much. One final question: who is going to pay for your technology?
The healthcare providers, so the NHS, the HSC, and the equivalents within the rest of Europe. So again, national healthcare providers will have the most gains from our platform.
Okay, thank you very much, Shona. Thank you very much.
No problem. Thank you.
Thanks, Shona. Ja, hier geht es Schlag auf Schlag weiter.
And we will carry on with team number 3, and that's the TreatMind GmbH.
Hi, I'm Anne.
And I'm Patrick.
And we are the founders of TreatMind. Our mission is to raise awareness and fight the stigma for people with a borderline personality disorder and help them survive their daily mental crisis. This is why we have created the MySkills app.
As a proactive companion app, MySkills offers people with a borderline personality disorder a personalized toolbox that supports them in their daily life and therapy. MySkills reduces mental crisis and self-harming behavior in a very smart and personalized way. Those affected engage in therapy on a daily basis without realizing they are doing therapy.
The Digital Health Now Award would be a great support for us to push our mission forward. Help us to prevent millions of mental crises. We and the affected people will thank you.
And I'm happy to welcome Anna Florin, the co-founder of Treatment GmbH, and Patrick Hartwig, as the CEO. Who do you address, the affected patients or healthcare professionals? We have a blended care approach that we pursue. In principle, the application addresses people suffering from a borderline syndrome, but the app can be used during the therapy, after and in patient treatment, or while waiting for therapy. How do physicians react when you tell them about this solution? Is this a negative attitude because they feel that they are superfluous, or do they consider it as a complementary approach? Well, in fact, and we were aware of this, the therapists and everything in terms of health professionals that work with borderline syndrome patients are really enthusiastic about this app, because this is an everyday support and assistance where therapists can't be around. And since the persons affected suffer such extreme crises and actually feel about 9 times more than we do, they desperately need something that supports and assists them in their daily crises every day, whereas the health professionals are really convinced about our solution. We've talked to many people to provide the best possible assistance, and we're so happy that our solution gets down so well with people. How do I have to imagine this in practical life? The patients affected feed the app with the data that they want to reveal and disclose. Is there an interface with the therapists who actually can react or respond timely? Well, the basic idea is that the patients affected interact with the app during mental crises. So when they're under a lot of stress or would commit suicide or whatever, and through the exercises and through the skills, the way of thinking is directed in such a way that dysfunctional reactions are avoided and reasonable actions taken, especially if they are confronted with emotional problems, or when they have to do their homework, or when they actually are expected to do a diary. So these are all things that they can do with our app and then digitally submit them to the therapists in the format of PDF files. Or they can actually bring it along to the therapist. So we don't have an interface to a portal yet. This would be the next step for the future, but at present they can actually share this through export functions. Before the long break, we had Gelinde Benzuk in our panel discussion, who insisted that digital health applications should always focus on patient benefit first, based on patient surveys. How did you develop your app? How many patient expertise has been involved? Lots of it. The idea was born during my work on a ward, and I first talked to the patients affected, and I said, would you like this? Could you use it? And this is what we currently do. We have many interviews. We have lots of questionnaires that the app uses, fill in and send us, and this is how we actually incorporate every little suggestion. Brief answer, please. How expensive are you? We have no official prices yet. The prices will arrive when we're included in the DIGA list. So you've submitted the application. Yes, it's following now. Well, thank you. That was team number 3.
Danke dir, Claudia. Somit kommen wir zum nächsten Team. Das ist ein deutsches Team mit internationalem Hintergrund. Wir begrüßen Boca Health mit dem Gründer Alessandro Ferrari.
And we would like to welcome Boca Healthcare with Alexander Ferrari.
Every year, around 30 million people worldwide experience dramatic symptoms such as extreme fatigue, breathlessness, collapse, and a sense of imminent death related to 2 chronic but deadly diseases: heart failure and kidney disease. To overcome this global problem, Boca Health has realized the first portable device able to measure accurately the hydration status of the patient and to give to the medical doctor a tool for the fluid management of the patient in and outside the hospital. Boca Health is composed by a portable device connected via Bluetooth to a smartphone application that is able to measure and keep track in a time period of changes in body fluids and detect abnormal events such as dehydration or overhydration. My name is Alessandro Faragli. I'm a medical doctor and researcher in cardiology at Charité University in Berlin. Join our journey and invest in Boca Health.
Alessandro, vielen Dank für deine Einreichung. Vielen Dank für deine Teilnahme beim Digital Health Award. Herzlich willkommen.
A very warm welcome to you.
Ich hoffe, du kannst uns hören.
You can hear us? I can't hear you, Matthias. I'm sorry.
Okay, das klappt soweit. Also, Alessandro, ich sehe, du bist selber Arzt und im Kontakt mit Patienten. Ich sehe aber auch, dass du gerade
I can unfortunately can't hear anything.
Wer kann mich denn hören? Claudia, kannst du mich weiter?
Hear me. Claudia? Well, very low. It's very, very
Claudia,
low.
kannst du mich
Claudia,
hören?
Can you hear me?
Hallo?
Hello? Okay. I can...
Hörst du mich, Alessandro?
Can you hear me, Alessandro? Yes, I can hear you really well.
Genau. Alessandro, hörst du mich auch weiterhin oder ist es weiter?
Now I can hear you.
Okay, auf ein neues. Vielen Dank für die Geduld. Also, herzlich willkommen beim Digital Health Award und vielen Dank für deinen Beitrag. Wir haben gesehen, du bist selber Arzt. Was hat dich, offensichtlich hat dich deine tägliche Praxis zu deinem Unternehmen inspiriert. Kannst du uns ein bisschen mitnehmen, wie diese Entwicklung vorangegangen ist?
Can you actually take us along on this journey? Well, the initial idea was triggered by my dad's experience when I was not a doctor yet. He was a heart insufficiency patient, and he was suffering from particularly this problem. In other words, he suffered various conditions, heart conditions, and we had to cater to this during the daily routine. So if they drink more than a liter of water, then the risk of ending up in hospital is very high. Later, in my clinical experience, I learned that patients with heart insufficiency often end up in hospital because they're overhydrated. This was one of the reasons why we decided that we use a software and a device to measure the liquids in patients and not in future also avoid overcompensation. So that was the reason.
Okay, sehr gut. Vielen Dank. Jetzt haben wir dich ja gesehen im Video, dass du euer Tool, euer Device bereits angewandt habt. Ist es denn so, dass Boca Health, du hältst es schon in die Kamera, vielen
Boca
Dank.
Health, yes, you're holding
Gibt es
up
denn
to
mehr
the
als dieses
camera.
eine Exemplar?
So
Ist es
there more than this one
in Benutzung auf
device
Stationen
in
auf der
use?
ganzen
Is it
Welt?
already being used in wards around the globe? We're still in the development stage. The device is ready. An industrial version is ready. We're undergoing certification right now. We're going through the first study now for validation. This has already been completed, but then we want to go for a clinical study that's planned, but this can only start after the certification. And what we've also done, we did a study at the Charité in Berlin with 50 patients to refine the software model. And with this model, in 6 months' time, we can know whether the patients are okay or not. And we did this in combination with another device that's already certified, and we actually used it to develop an algorithm. So Boca Health is not only this device for measuring, it is actually a combination between software, where we collect various parameters when we say, okay, how does the patient feel? There's this clinical part, and we can develop trends, and we know over time whether the patient is doing
ganz kurz,
fine or not.
wie
Just
sieht euer
briefly,
Businessmodell
what is
hinter
your
dieser
business
Dualität aus
model,
Hardware und Software aus?
for
Wer soll das am
software
Ende
and hardware?
bezahlen?
Who pays for it
Übliche
at the end
Frage.
of the day? We have 3 different services, and we offer a model where we generate revenue with the software, and this is why we want to apply FDIGAs so that this can be reimbursed. We say we actually hand the device over to patients. Patients do not pay for it, and this is also reimbursed as a medical service rendered to patients at home. And then there is a certain reimbursement model for the measurements. So this is the first service rendered, and there is a reimbursement associated to the consultation. So the device as such would cost 1,000 euros, but the patient wouldn't pay for that because we want to install a certain reimbursement scheme. We've already filed the first application, but we're actually also based on other devices that are also already considered medical devices that are reimbursable. So the idea is to generate software-based revenue. Each measurement, for instance, at present costs 5 euros, but this will also be covered by the reimbursement model.
Danke dir.
Thank you. Super. Thank you very much.
So now that's the 5th solution after we have had this, we had a speech level, we had a mental health solution for burnout, and we had the fluid and liquidity management for heart insufficiency patients. Now we'll talk about solution 5, presented by Julian Naskold. He's the managing director and co-founder of CliniServe.
Hi, my name is Julian Naskold. I'm co-founder and CEO of CliniServe. CliniServe is an interdisciplinary and international team of 15 that solves the nursing crisis by enabling new nursing work models. We combine a task management with a staff disposition solution, ensuring that the right employee takes over the right task at the right time. That may sound simple, but we're actually the first nurse interface that's in the market right now. We have 20 customers in Germany, such as UKSH, that deployed our solution to help nurses. And actually here at the German Nursing Conference, we were just awarded with the iCare Award yesterday for our solution. Also, partners realized the potential in our product, since companies like Siemens, Bevatec and Miele rely on our service to help nurses reach their goals better. What made us unique is that we have a data pseudonymization scheme which ensures that we only need IT integration when it's really necessary, which allowed us to enter the market way faster and reduce cost and risk for customers. Thanks.
Also here, my hope is that you will talk slower now than in your 1-minute video. Hi, Julian. It's great to have you here. And thank you for presenting your solution, a little teaser movie video. And we have now made progress, and we're not talking about nurses, and I cannot imagine that they want to get familiarized with yet another technology. So what is your argumentation? What's your line of argumentation that you use? It's quite the other way around. I think we are even more sought after than before, because after the exodus of the last wave, the staff is in need of supporting solutions so that they have more time for their patients. This is why the feedback is super positive on the market so far. Which we have seen different tools that are offered by the app. From your view, what is the thing that will deburden the staff industry, the nurses most? And in which stages will you roll it out? So what goes along with Corona and which works rather well is the digital patient communication from the ward, so that staff is enabled, when they have contagious and infectious patients, that they save ways to run within their wards. So that saves a lot of time currently. And also another advantage is that we can do the software integration with the light call, for instance. So this saves the transport way and the internal process that are just as much, so that they go on more quickly, and that the staffs nurses have more time for their patients. So what's your training expenditure on site? How big is the effort? As for time, it's just 20 minutes when there is the handover of the shifts, and we try to keep it as fast as possible. So it is about establishing trust and to give them the possibility to ask questions to the development. So what happens with my data? Can there be a tracking because of the from the management side, but also questions of comprehensions. This is something that many people do. They seek advice what should be included next, so that the value is even bigger of this tool. And tracking of the management, is that possible? No, it's not. We capture staff data on a pseudonymous basis, and with this is absolutely impossible to make a contact or to make an association to the respective staff. Can it only work on your own device, or will you also make available the hardware? Optionally, we offer rental devices that can take along the nodes, and in order to start them up. But for the rollout, 4 to 5 devices per ward will be enough, and they will be handed over with every shift in an analogous fashion to the ward phones. But it only serves the patient-caregiver communication and supports logistics, or can a staff on the ward, can they also document administration of medication to patients, or can it also report events, like when that's a stage 3 patient-caregiver communication and transport light call, or when somebody needs to go to the toilet, or the care documentation. You can document those things in a mobile way, and sometimes it happens automatically when a medication, a pill was given, like ibuprofen 600. So that would be the next level of automation. But as those interfaces always take a lot of time, it is important to us that we can start right away, because otherwise I would come back to your first comment. They need to help now. The staff needs to help now. Those were your 5 minutes. Thank you very much.
Ja, vielen Dank, Julian, vielen Dank, Clinisurf. Tatsächlich ist es ein Startup, was wir bei EIT Health seit längerem begleiten und auch sehr froh sind, sie in unserem Portfolio zu haben. Wir kommen zum nächsten Startup. Wir heißen ganz herzlich Crescent Medical aus den Niederlanden. Willkommen auf der Bühne. Hello, Sammy.
Trauma surgeon in a big education hospital. We came into serious problems when COVID hit, and we were in need of innovative devices which enables us to keep our teaching up to standard. And because of our innovation platform, we connected to Crescent as a hospital.
Our vision is to accelerate the digital transition of healthcare education. This is why we developed a smart head cam, the Crescent Vision. We're using a wide angle to immerse the viewer into the operating room, and we have a zoom lens to really show the detail of the surgical procedure in the operating room.
I do like to help to improve these educational tools because we really need them now and in the future.
Hi, Sammy. Happy to have you on the stage. Can you hear me well?
Yes, it's a little bit low in volume, but it should be working.
Okay, we'll manage. So thanks a lot for handing in your application. So I gathered from your application that you work together with the University Hospital in Delft. And the Corona crisis has been mentioned as a kickstart for your product, but for how long have you been working on such a technology?
We actually started already back in 2017 on the technology itself. And back in 2018, we got in contact with a tropical surgeon who's a gynecologist in Zambia and Tanzania and several other countries. And he was actually the first one to approach us and saying, hey, this technology should find its way into an operating room. So since 2018, we've been iterating the product multiple times to perfect the device for telemedicine and telecommunication within the operating room.
Okay, and is your device mostly used for medical education?
Yeah, that's correct. So we decided to focus the technology on medical education. However, we already noticed since our last launch last week at Medica in Düsseldorf that there are multiple applications within the hospital and even the ambulance where such a device and such a technology can be applied.
Okay, and I may say that you choose a path that is not very familiar to most products, that you issued your product in the developing country, in the global south, and it has now been taken up by hospitals in the Netherlands. How is your share of usage of that product at the moment?
Currently, it's mainly academic hospitals and teaching hospitals in Western Europe. This is mainly due to COVID, travel restrictions, which is another opportunity for our device, has resulted in us staying close to home. So collaborating with a lot of surgeons and academic hospitals in the region. However, we are still in close contact with this tropical surgeon because obviously we would like to have him use one of our products as well.
Okay, and how much is one of your head cams, if I may ask?
Yeah, that's a good question. We're currently exploring different pricing points where you can get the device for a subscription model. But currently the device is targeted at 6,500 euros. And compared to conventional cameras inside the operating room, which require extremely strict installation policies from the hospital, they can vary anywhere from 500,000 to 50,000 euros to get a good camera inside the operating room. And because we leverage the position of the surgeon, who naturally is positioned in the perfect angle in the operating room, we bypass this problem of installing in the whole operating room.
Okay, that sounds very good. Did you need to oblige any medical certification processes in developing this product?
So we decided to launch the product under a CE certification, so Consumer Electronic Communication certification, mainly due to the COVID regulations to speed up the development and speed up the introduction into the market. We are not a diagnosing tool yet. This is something that we'll explore further down the road. This will be a software update mainly. But we decided to speed up the development and the response for COVID. And since we are on the head of the surgeon next to the glasses, which also cannot be sterile, there is no need for the device to be sterile, because the second the surgeon would put it on his or her head, it loses the sterility. So there's also no necessity to have it sterile.
Okay, Sammy, thank you very much for your input, for your thoughts, and for your presentation of Crescent Medical.
Thank you.
I'm very happy with your selection. It's very colorful, all healthcare professionals we have addressed at least once, and now we move on with the team number 7. Now we'll get the medical device technology and sensors, and Gernot Zimmermann will explain to us. He's the CEO and co-founder of Synteract. And
what would you do without your hands?
Glove.
You couldn't work, you couldn't type, you couldn't grab. After a stroke or hand injury, a rehabilitation is necessary but can often be time-intensive and unmotivating. We found a solution to combine the necessary hand exercises with motivating computer games with our smart glove, measuring precisely every finger movement and still being portable and affordable. Let's see how this works. We created a bunch of games, some with more action focus and some with more to think. In this game, for example, I can steer the rocket by opening and closing my hand. While playing, the therapist can monitor your hand movements and this way keep track of your rehabilitation progress. We are Synteract. We bring gamification to rehabilitation.
So, looking forward to Gernot Zimmermann, who is switched in. Yeah, only on the phone.
Okay. Hallo, schön, dass du da bist.
Great to have you here. That's something that is one thing to get in contact with patients and another thing to get in touch with doctors and other HCPs. You want to deal and liaise with physiotherapists who tackle their task in a less playful way, or at least want to do that. What's the reaction from the side of the physiotherapist? Well, first, thank you for the question. We we set out as a Jugendforschprojekt. The youngsters are doing research, school project, and then Medica and others. We were invited, and there we have realized that therapists prefer the glove because it means an additional support to what they currently have. Patients don't have to press a rubber ball at home, but can go on carrying out the exercise, the physical exercise, and the therapist has the possibility to monitor the progress. So what have I done today? What did I manage to do yesterday and today? And when could my rehabilitation be completed? So it's meant to be rather a support than a substitute. So my physiotherapists that I know from the inside have Fango, a stretcher, and a gym room. But when it's going well, I have never seen a computer monitor. You are talking about feedback from physiotherapy. How closely is the patient accompanied? There are different practices. Before we had customers that were plus 70, but also young patients around their that are 17 years old. And we have different kind of practices. Some specialize on the youngsters and children, but also general. Digitization, I mean with monitors, maybe that's not customary and not even existing everywhere. And you could train it on the laptop, but every patient has a laptop or a PC at home, or at least a smartphone that allows you to do the training with our glove. So that means that's possible. I didn't talk about the patients, of course. They are well equipped, but the physiotherapist practices, whom I know, cannot monitor whether I have done my exercises at home. How do you reach them? We will reach them via the laptop that we make available to them. And the most basic notebook is okay to put on this app, and so that they can monitor their patient's exercises. But the patient with us is in the focus, and they are supposed to be motivated to do the exercise at home. And this we achieve with the glove. Whether or not the therapist then keeps observing the patient is their choice. So now the question to you, the funding.
Fachbereich natürlich nochmal erschwerend hinzukommt.
Our funding application we have submitted already. Now we're waiting for the feedback, and of course we hope that we will get it refunded. Our price is approximately 600 euro. Even every private individual can afford it. Did you say 60? No, I meant 600. Some private individuals in my peer group cannot afford that, but okay. Thanks for your contribution. Thanks to you. Mathis, we have come to
Genau, wir nähern uns dem Ende des Wettbewerbs, aber gleichzeitig nähern wir uns auch der Verkündung der Siegerteams. Die Spannung steigt also. Ich begrüße jetzt Inuka aus den Niederlanden.
One in 5 employees every year struggles with burnout, anxiety and sleep challenges. Yet the majority never seeks help. Now with COVID, isolation and uncertainty have only made this worse. Data shows that 80% of employees who go burnout never ask their employer for help, even though most organizations have a lot of solutions available. Inuka Coaching is on a mission to change this by keeping it simple and human. With a 5-minute well-being scan, any employee can track their well-being to see if they are green, resilient, orange, at risk, or purple, in a danger zone. Based on this well-being scan, Inuka Coaching connects them with existing support a company already offers and with one of our certified Inuka coaches. All our coaches are trained in a proven methodology. A scientific pilot showed that 82% of people who score at risk go within 4 sessions back to resilience. This way, Inuka Coaching identifies and cares for employees early on, and saves employers burnout and absenteeism costs, and solves the challenge for how to care for their struggling employees, online, anytime, anywhere. Want to join our mission to make well-being accessible for employees or learn more? Meet us at inuka.io. Thank you.
Robin, thank you very much for applying to the Digital Health Award, and very warm welcome to the virtual stage. With Inuka, you are targeting employees, but at the same time, you are targeting employers. So who do you reach out to? Is it the companies that you approach first, or is it the people working for them?
Yes, first the companies or the organizations. So work with all kinds of companies, all the way from Tommy Hilfiger to large healthcare organizations. And then once the directors or the managers or the HR directors say, okay, I want to continue with this, they then facilitate that we do the activations for the employees and reach out to them.
Okay, and what is the uptake by employees when their managing director says, well, we do want to do something good for you, we have this app, now go play with it, basically?
Yes. So there's their scan that we do. So that's the app part. And we have the coaching, right? So for the scan, this ranges anywhere between 5 to 80%, depending how young the population is and how excited the managers are to do the introductions. I think on average, I would say we have about 30% uptake for organizations with thousands or more employees. To give you an idea for the scan, so the self-scan. Based on that, then the company knows, like, oh yeah, of those employees, what percentage is resilient, green, orange, at risk, or tough place, purple, and also per department. And then for the uptake of the coaching, that of course is less because that's only that part again taking up. So of the total organization, coaching is on average about 5 to 20%, again depending on the size of the organization and how young the population is.
Okay, you claim that you only need very few sessions or visits per app to measure an employee's resilience, and also consequently claim you don't need that many coaching sessions to restore that resilience. Yeah. In terms of coaching, is that something that varies from company to company, or is it an approach that is similar across all organizations?
It's similar to all organizations. It does vary from where people score on how well they're doing. So the more people are towards the orange or the red zone, the longer it takes on average. For people in the orange zone, which is really the target group of employees, it takes on average 3.3 or up to 4 sessions to get someone back to the green zone. And that's also, I think that's really important about our innovation, because typically, I think historically, coaching is a very long-term or a very sort of for the upper layers of management or sort of talents or people that have problems kind of targeted. And what we really did is by doing it this way, we make it accessible for all layers of the organization and people with all kinds of educational and vocational backgrounds. So that's really the mission also that we're in for here.
Okay, so initially you said you target employers with your solution. Is there any opportunity or possibility for the employees that work in the app to extend the visit on the app into their private sphere? Is there something they can take away, maybe for their own personal agenda?
Oh, in fact, I think about half of the conversations are about their personal lives, not about what happens on their job. A lot of times employees are struggling with, for example, loneliness caused by COVID, or a divorce that they're in, or a chronic disease they have, or that they're like are putting on weight and want to lose weight. So a lot of the times the conversations and the support that we give for these employees are not about what's happening at work, but it's about something that's happening outside work that they take to work and impacts them. And so this is, we never force employees to talk about something about the company, but a lot of the time it has impact, like it always has an impact on how they function at work, of course.
Okay, so you mentioned that they talk about very private and delicate aspects of their life. Is this something you assure them of, do not share with their bosses?
Yeah, definitely. Yeah, so there's a couple of things that we do, because that's of course crucial. If we would break that, then we would never work as an innovation, right? So it's very important to reassure employees that we would never share any of the information that they share with us. And there's a couple of things how we do it, but definitely we are ISO certified. So we have the process in place to ensure like that the data is safe and protected, and we do not share it with the wrong people. We also, when you sign up on the platform, you can sign up with any email, also a private one, or one that doesn't reveal your identity, as long as you use the company code. So it's not retraceable back to you. And also the coaches don't know who you are. So there's a lot of things that we do. And also that's what we sort of, when we do the onboarding in the organization, this is of course first topic we always address to employees.
Okay. Thank you very much, Robin. It was nice having you on the stage, and maybe we will hear from each other later on in the course of that award. Thank you very much.
Thank you very much. Bye-bye.
For those of you, it means that sharpen your pencils now. We're nearing 5 p.m. We move on with team number 9 and then 10, and then we'll have the voting. And the channels will be open then, and you can vote for your favorite. I would like to ask you to do that. We talk about Layla Fertility.
The Layla Fertility Code is a CE-certified medical software for infertility diagnostics. We help women and couples to understand why they struggle to conceive, which, by the way, affects each day 25 million Europeans, or 1 in 6 couples worldwide. Nonetheless, only 10% seek medical advice with experts who usually sit in fertility clinics. And this is mainly due to stigma and high costs. And that's where we come in. The Layla Fertility Code takes both patients and doctors for individualized diagnostic steps, giving evidence-based recommendation for diagnoses and the most appropriate therapeutic treatments. This allows us to reduce average time to diagnoses from 4.5 years to 2 weeks. We fight for fertility, and we hope you do too.
Ja, hallo, schön dich da zu haben.
Hello, it's great you're here. Thanks for participating. Regards from Berlin. Caroline Kuhlmann, because I have 2 names here and it wasn't clear until the very end. So I'm really happy that you're here, that you have actually been chosen to take part in this race here. It's something that you address which is very difficult for the people that are affected. How do you address the doctors and the patients with your solution? Yes, unfortunately, it's a delicate topic and it's also stigmatized very much. In the first step, we focus on the woman that has the unmet wish to have a baby, and that's the target person that we want to assist with our fertility code. It is about saving time and knowledge and control and how somebody can enhance their fertility. How you have rightfully addressed it, we cannot do it alone. It's really important that the stakeholders, the gynecological outpatient practices, but also the fertility clinics, that they are involved. This is what matters. And this conversation with this gynecological practice with such a personal topic, it's more than work of trust here. So what's the first reaction when you tell them we want to assist you with a digital solution? We have launched an own market study with 1,500 women in order to understand their motivation when it's about unmet wish to have a children. And that's quite clearly the gynecological practice. We know that the gynecological outpatient practice does not necessarily set the focus on fertility, which is that the experts in a fertility clinic that are endocrinologists, and only maximum of 10% of all couples arrives there. It's stigmatized. In vitro fertilization, this is how it is associated, and it is really a giant step for the couple to seek help on site. Where we position ourselves, this is where the gap is. We want to close this gap, that we want to fetch the people from the gynecological practice. We want to accompany them and to want to give them a possibility to understand why they can't have a baby. So it's a fertility diagnostics, and then we want to show up therapy options for them. And that can also be that we send them to or recommend a fertility clinic. We try to recommend to the woman what is the best. It could be change of lifestyle. It can be further diagnostics by expert staff or in vitro fertilization. So would that then be the first step when women want to have a child? So could it be a first step to download your app and to populate it with the laboratory results that I have collected so far, whereupon you can then take a decision how my future strategy will be so that I can get a child? Oh, this is where you make the contact. It's a web-based platform, what we have. We are a native app. You can reach it via the notebook, via the laptop, via the smartphone. And it is our goal that women, because of our algorithms, that they go through the process and at the end can actually have a chat with one of our doctors of the fertility clinic where the results are identified and where you can discuss potential therapies. So it's very much individualized questions we ask in a medical survey, which is rather comprehensive and long. So we really try to reflect a conversation with a fertility clinician, but it's also based on laboratory results. Not every woman gets the same blood parameters, but recommend what we consider to be necessary in order to be able to place a diagnostics. So you need to do some marketing. You do it for altruistic reason, but you have to make your living on that. So what is your brand communication like? What does it look like? It is directly directed to the woman. It's very honest. We choose ways with cooperation with cyclers, applications of fertility trackers that have an access to that very woman already and realize if the woman has difficulties getting pregnant. But on the other hand, also we use marketing channels, Instagram, Facebook, but also Google directly. And at the end of the day, ideally, long-term, also via the gynecological practices. The business model or the business case looks like that. The woman visits our word form and pays €299 for the access and the medical consultation. Spent over which time? Hopefully as quickly as possible. It depends upon the cycle stay of the women. To do it between the second or fourth day. In the best case, it takes a maximum of 3 to 4 days, but it can also last a full month. And that we have to wait until the second or third or fourth day, so that it takes maximum 14 days. So, Mathis, the honor is yours.
Vielen Dank, Claudia. Die Spannung steigt. Ich bin begeistert über unsere Startups und möchte jetzt als allerletzten Kandidaten das Startup Asmed aus Frankreich vorstellen.
Introduce to you Asmed from France, the 10th startup.
AZMed automatically detects any abnormalities on X-rays to allow radiologists to focus not on the images, but on the patient. And during the last 3 months of the Textiles program, we deployed beta versions in 10 radiology centers. And we didn't just create an algorithm. We've built a software designed with and for radiologists. And I will show you how. Our deep learning technologies can spot any abnormality, such as a fracture, on any X-rays, at any time, anywhere, in less than a second. But we don't just show the fracture. We edit a pre-report that is easily modified by radiologists in a few clicks. And we offer this solution to hospitals, radiology centers, and to the existing software editors.
Lisa, thank you very much for your presentation and a very warm welcome to the Digital Health Award 2021. You said that AZMed has been piloted in 10 radiology centers. May I ask, what has come out of this pilot project?
Yes, so actually this video is really old. It's like 2 years ago. I think my colleague did a mistake when she submitted the video. She didn't know that it was for today. Today we have 250 partners. So it's great. It shows that we rise a lot. So, and we are not just in France. We are also in Germany, actually, in the UK, in Argentina. So yes, we've developed a lot since then.
So you were kind enough to take us on your impressive growth journey over the past 2 years. How do you sell your software, your device, your product at a radiology center?
So we sell at private radiology centers, but also hospitals. So we contact radiologists or also emergency physicians, and we ask them if they want to get a demo of our solution, and then we do presentations. And then because it's for radiologists, but also emergency physicians, we have multiple meetings with hospitals, but also the emergency service and radiology service. So that's how we handle the partnerships.
Okay. And I don't know if this is a tricky question, but do they like what you propose them? Or are they feeling maybe a little threatened by your technology?
So when we started, AI in radiology was not known. And it's true that, a lot of doctors were kind of afraid of AI and they thought that maybe it would replace them. But today, the market is more mature and they understand that for AI, and maybe not for every company, but for us specifically, we don't want to replace doctors. We want to make them gain time and make less errors. So for now, they're quite happy with the solution because it can help them, and it can also help emergency physicians, because today not every radiology is going to be read by a radiologist. And there's a lot of radiology today. I don't know, in the video he didn't mention it, but there's been an explosion of X-rays in the past 10 years. So we have a lot of X-rays, but not enough doctors to analyze them. So our solution is kind of helpful for them.
Okay. And what is the business case that you propose to those doctors, whether in radiology centers or in hospitals?
So for the business case, we show them some images, and we show them that with our solution, they can find the fractures quite easily. And yes, that we show them our results. We have a lot of numbers, and we did a lot of clinical studies. So based on that, they can understand how our solution can help them.
Okay. And you said that your software can detect abnormalities within 1 second. What is the usual time that a radiologist would spend on detecting that abnormality? So what is the time-saving aspect of your solution?
So based on our clinical study, we've shown that the radiologists are 36% faster, because we can't have an exact number, because sometimes it will be emergency physician who will read the radiology, or maybe some radiologists. But based on our studies, it's a gain of 35%.
Okay, so your software has a time-wise advantage of 35%.
Exactly.
Okay, and that's 35% time more spent with the patient.
Exactly, and 20% less errors.
Okay, well, this is almost more important for me as a patient.
Exactly.
So, dear Lisa, you have had the honor to be closing this pitch event. Thank you very much for your presentation of AZMed. I'm very happy to have learned so much, not just about your company, but also to all the other startups that presented themselves today. To all of you, a big thank you for making the Digital Health Award 2021 possible. I will now switch to German. Und Claudia, ich glaube, wir können auf eine tolle Runde an Startups und jungen Unternehmen aus ganz Europa zurückblicken, die Sie heute präsentiert haben.
Fantastic round of startups. Yes, diverse topics, diverse teams. And what's in it? Winning the Digital Health Award? Well, you'll find out talking to Alexander Krawinkel. Sorry for interrupting you. And you, ladies and gentlemen, are now called upon to participate in the poll. If you should not be able to click on the link, please refresh the page once, and then you're good to go. Mathis, do our viewers need a summary of the 10 projects?
Ich würde sagen, da wir recht gut in der Zeit liegen, würde ich vorschlagen, dass wir jeder nochmal die Startups vorstellen, die wir auch interviewt haben, um eben in 1-2 Sätzen eine kleine Erinnerungshilfe zu geben. Wenn Ihnen das Setting, liebes Publikum, des Digital Health Awards nicht glamourös genug ist, was ich mir kaum vorstellen kann, können Sie sich vorstellen, dass Sie jetzt beim Eurovision Song Contest sind und einfach alle Einträge
Eurovision Song Contest
bekommen.
and you get the review, and then you cast your vote. Manuel Opitz was the first contestant for Deep Eye Vision platform for fighting macular degeneration. Supporting physicians in their diagnosis.
Genau, ich habe das Glück, dass ich ja erst spät dazugekommen bin, deswegen kann ich jetzt noch einigermaßen beschwingt das Kids Speech Lab aus Dublin vorstellen, mit der Gründerin Shona Darcy, die eine Fernscreening- und Interventionsplattform für Logopäden und Sprachtherapeuten von Kindern aufgesetzt haben.
Anne Florin is number 3 and Patrick Hartwig, My Skills, Fighting Burnout Patients.
Alessandro Ferrari von Boca Health aus Berlin, der das digitale Management des Körperflüssigkeitenhaushaltes von Herzinsuffizienzpatienten
body liquids for patients with heart insufficiency. Number 5, Julian Nast-Kolb, Cliniserve, Support
Semi
for
Andari
Nursing.
von Crescent
Number
Medical
6,
aus den
Semi
Niederlanden,
Ardani of
der eine
Crescent
intelligente
Medical
Kopfkamera entwickelt hat, die den
with a
Betrachter
smart
direkt in den
head
Operationssaal
cam
eintauchen
that
lässt.
actually provides immersive experiences in the OR. Number 7, Gernot Zümermann of Synteract,
Robin
the
van
Smart
Dalen von
Glove.
Inuka aus den
Robin van
Niederlanden,
Dalen of
die das
Inuka,
Nachverfolgung
number
und das Coaching
8,
von emotionalem
coaching
Wohlbefinden
of
bei
the
Mitarbeitenden und
emotional
Angestellten übernimmt.
well-being of employees. Number 9, Nora Antonella Kuhlmann, Caroline Mitterdorfer, Lila
Und
Fertility
schließlich Lisa
for
Alem von
reproductive
ICMed,
physicians. And
die
finally, number
in ihrem
10,
Unternehmen eine
Lisa
Software
Alem
entwickelt
of
hat, die Radiologen dabei hilft,
Azimed.
Anomalien auf
They
Ultraschallbildern in weniger
have
als einer
actually
Sekunde
developed
zu
a
erkennen.
software that detects anomalies in
Genau.
X-rays within less
Genau,
than a
Alexander,
second.
bevor wir ins Gespräch starten, möchte ich ein paar Takte über mich und auch EIT Health Germany
I would like to say a few words about
Wir bei EIT Health Germany
We
sind
at
natürlich immer
EIT
daran
Health Germany
interessiert,
are
Gründern
of
zu
course
helfen. Und wir tun das
always
nicht nur in
interested in helping
Deutschland mit
customers,
EIT
not
Health
only in
Germany, das
Germany
ich
with
heute
EIT
vertrete, sondern
Health
wir tun das
Germany
in ganz
that I
Europa.
represent, but
Und
we
so
do
freuen wir
this
uns
all
insbesondere heute,
over
so viele
Europe.
Bewerbungen
And
aus
we're happy
unterschiedlichen
that we
europäischen
received
Ländern
so many
präsentieren zu können.
submissions from
Ganz
many other
besonders freuen wir uns
European
darüber,
countries. And we're
dass ein Teil
particularly
der heute
delighted
vertretenen
to
jungen
see
Unternehmen
that some of the
zumindest für
young
uns als EIT Health Germany
startups
alte Bekannte sind.
are familiar
Das sind Unternehmen,
faces,
die
at
wir
least
schon
for
seit
us,
vielen Jahren
EIT. This
begleiten
is
und
startups
uns
that
über
we've
deren
accompanied for
Entwicklung
many
freuen können,
years, and
seien
they've
dies
really become
Investments,
friends.
Zulassungen und
We've helped them with
Zertifizierungen oder
investments,
eben Partnerschaften
certification,
mit großen und
approvals,
relevanten
at
Playern im
times
Gesundheitsbereich.
with relevant
Wir sind immer
players in the
besonders
health
stolz
sector. We're
darüber, wenn
always
Startups ihre nächsten Ziele
extremely
erreicht
proud
haben,
when
nachdem sie
startups
eins unserer
turn
Programme
into
durchlaufen
scale-ups
haben.
once they've
Das können
actually
große
gone
europäische
through one of
Pitch-Wettbewerbe
our
sein, wie das European
programs.
Health
This can
Catapult.
be
Genauso
major
können das
European
Programme sein,
pitches,
die
but it can
Startups bei der
also
Suche
be
nach Investoren
programs
unterstützen,
helping
wie das Venture
startups in
Center of
finding
Excellence.
investors
Und das
or
können auch
centers of
Programme
excellence.
sein,
Or
auf
it
die
can
wir
be
bei EIT Health
programs,
Germany ganz besonders stolz
and
sind.
I'm particularly
Nämlich
proud
unsere
of this at
hauseigenen
EIT,
Programme
and this is
Startups
our
mit Pharma
in-house
und Startups mit
programs
Healthcare Providers.
linking startups with
Das sind
healthcare providers
Programme,
and
die
pharmaceutical
Startups mit eben
companies. These are
Pharmaunternehmen und
programs
Leistungsträgern im
that
Gesundheitswesen
actually
zusammenbringen.
connect
Ich gehe
startups
deshalb auf
with
diese
pay
beiden Programme so
authorities.
deutlich
I am
ein,
actually mentioning
da
these
ich
two
anhand des
programs in such
Beispiels eines
such
Teilnehmers des
detail
letztjährigen Digital Health
because
Awards
I
zeigen
want
möchte,
to
wie wichtig
give
für
you
uns
an
diese Konferenz
example,
ist.
last year's
Im
participant,
letzten
to
Jahr
show
hat
how
Fimo
important this
Health aus
conference is. Fimo
Nordrhein-Westfalen hier
Health
ebenfalls
from
teilgenommen und
North
wurde
Rhine-Westphalia
verdientermaßen
took place
auch als bester Teilnehmer
and
mit dem
was actually
NRW-Sonderpreis
awarded
bedacht.
with the North
Seitdem
Rhine-Westphalian
hat Fimo
Special
Health
Award.
eben auch an einigen
Since
unserer
then,
Programme
Fimo Health
teilgenommen,
has
wie
participated
etwa
in
dem
some
Programm
programs
Startups mit Pharma,
such as
wo es sich
the
und seine
Startups plus
Technologie gleich 5
pharmaceutical
großen
companies,
Pharmakonzernen
where
vorstellen
the
konnte.
technology was introduced to 5
Dieses
big
Beispiel
pharmaceutical
zeigt,
companies.
wie
This
sehr wir den
example
Digital Health
shows
Award schätzen
how
und mit den
much we
spannendsten
appreciate the
Teams nicht
Digital
nur aus
Health
Nordrhein-Westfalen
Awards
und Deutschland, sondern aus ganz Europa zusammenzuarbeiten und
how
diese dann
much
auch
we
im Anschluss
appreciate
die Möglichkeit
cooperation with
haben,
the
in
most
unser Netzwerk
exciting
mit aufgenommen
teams,
zu
not only
werden.
in Germany, but
Mit
all
diesen
over
Worten möchte
Europe.
ich
And
jetzt
with these
endlich
words,
auch
I
ganz
would like
herzlich
to
Alexander
finally
Krawinkel
welcome
begrüßen.
Alexander
Herzlich willkommen, Alexander.
Krawinkel. Welcome, Alexander. Well, good evening, and thanks very much for the
Aktuell scheint
invitation.
noch
I'm
etwas
happy
schief zu
to
gehen,
be
denn
here.
ich verstehe leider nicht, was du
Unfortunately, I
sagst.
can't understand you. I can't
Ich höre
hear
aber, dass du was
anything, but
sagst.
I can hear that you're saying. Let's try again. Test, test, 1, 2, 3. Can you
Ich
hear me
höre ein
now?
leises 1, 2, 3 aus den Tiefen des Raumes.
I can hear you like from outer space, very low. I simply carry on. Maybe you can hear me better gradually.
Super, steht da drauf.
Super, a lot
So
better.
langsam wird's, hervorragend. Also auf ein neues. Herzlich willkommen, Alexander Krawinkel, der Gründer und CEO von Fimo
the
Health.
founder
Herzlich
and
willkommen.
CEO of Fimo Health. Thanks very much for the invitation. I'm happy to be
Jetzt,
with you.
Alex, haben wir schon angesprochen, dass du letztes Jahr dich schon mal hier präsentieren konntest und auch Gewinner des NRW-Sonderpreises warst. Könntest du uns etwas über Fimo Health erzählen und was ihr eigentlich so macht?
Fimo Health and what you're doing? Sure. Most welcome. We at Fimo Health develop a solution to help fatigue patients as a result of MS, cancer, Parkinson's, and omnipresent in the media, of course, long COVID. And this fatigue is a clinically relevant, massive form of tiredness, where just a little walk, taking a shower, or playing with kids is so exhausting that patients can't do anything else for days. This fatigue actually correlates with many movement factors. factors, how much people move, how stressed out people are, but also temperature and noise can actually cause this fatigue. And we have developed an app to capture this information, and we've included some questions, and we've also included a course about mindfulness, nutrition, and sports therapeutic exercises. And with this solution, we help patients affected to proactively tackle their fatigue, but the data can also be shared with treating doctors for clinical patterns, but we also cooperate with insurance companies
Super,
and
Alex, und vielen
pharmaceutical
Dank.
companies.
Jetzt
Well, thank you.
haben wir schon
Great,
gesagt,
Alex.
dass ihr
We already
letztjährig den
said
NRW-Sonderpreis für die
that
FIMO-App
you were
erhalten habt.
awarded
Könntest du
with
uns so ein
the
bisschen
North Westphalian
mitnehmen auf das
Special
letzte Jahr? Du hast ja
Could
einige
you
Entwicklungen und auch
actually tell us something about the last
Anwendungsbereiche
year? You've already
aufgezeigt, die
mentioned some
ihr anbietet.
applications
Aber könntest
that
du so
you
ein bisschen
cover,
auf die
but could you
Reise
also
mitnehmen, die FIMO
sort of
Health im letzten Jahr seit der
describe the
Verleihung des
journey
Digital
that
Health Awards
FIMO
genommen hat?
Health has been embarking upon since the award? Yeah, sure. Lots of things have happened for us as a startup. Typically, on the one hand, our core infrastructure was expanded. We're now certified as a medical device. We've gone through the first studies proving that we can reduce fatigue, and we have been kept busy by long COVID because we saw a very strong need and a very strong demand from various sides. Over the next few weeks, we will actually launch our COVID fatigue app in cooperation with the sickness funds in the German-speaking region, but we're also in the MS environment and expect to file our application over the next few months to be able to be on the market with
Super,
various
das ist eine
products.
ganze Menge und
Super.
klingt auf
This is
jeden Fall
fantastic. It's a
so,
lot.
als ob euch das
And it
letzte Jahr
sounds
genügend
as if
Hausaufgaben
next
auch für
year
die kommende Zeit gegeben
had
hätte.
given you enough homework for the
Ich habe
coming
angesprochen,
seasons.
FIMO Health hat an dem Programm von EIT Health Germany teilgenommen, genauer gesagt am Programm Startups Meet Pharma. Was sind denn deine Eindrücke, wie das Programm euch in eurer Entwicklung unterstützt hat?
Has this program helped you? For us, this program was very valuable. We were involved in a special challenge about multiple sclerosis with Merck company, and it was really important to share this expertise of a pharmaceutical company. We were able to really exchange with the representatives, to compare the views and see whether there are cooperation options, see the mutual needs. This was so valuable for us, but also the accelerator program launched by EIT GmbH was very helpful. There were trainings not only restricted to the MS challenge, it was about the certification of medical device products, MDA, MDB to MDA, or how you can actually improve the design of clinical studies or have dedicated sessions to attract investors and to attract them to visit startups. And EIT helped us with many, many things, and we were also introduced to other interesting startups. So this was really a cool program that we love to participate in.
Ja, vielen Dank.
Thank you very much for this
freut uns sehr zu
recommendation.
hören.
We're happy to hear this.
Wenn ich noch eine Frage aus der Hüfte schießen darf, sozusagen. Du hast jetzt das Programm aus der Sicht eines Startups geschildert. Wenn ich dich vielleicht mal in die Rolle eines Pharmaunternehmens drängen dürfte. Was denkst du, wäre der Benefit, den Pharmaunternehmen aus dem Programm mitnehmen können?
I think the benefit primarily lies in the direct contacts, having a direct exchange with innovative startups that actually inject completely different views. We saw the other startups in the MS challenge. We knew some of them beforehand, but I think it is a fantastic opportunity to get this bird's eye view of what is available on the market in order to fine-tune and polish our digital health solutions, and whether there are also cooperation opportunities, because pharmaceutical companies often have completely different strengths in terms of marketing, development of drugs, companies. But in terms of the digital team, I can really say that you can still learn a lot, maybe even to expand your own product portfolio. And this is why for the pharmaceutical companies, it was pretty valuable to be introduced to a wide variety of startups. Super, Alex. Thank you very much for your view and the insights you've provided us with regarding female health. Now,
so langsam aber sicher zum allerersten Höhepunkt des Digital Health Awards 2021 kommen. Das ist die Verleihung des NRW-Sonderpreises. Der ganze Digital Health Award wird ja vom Ministerium für Wirtschaft, Innovation und Digitales Nordrhein-Westfalen ausgerichtet. Und deshalb schauen wir natürlich ganz besonders auf die Einreichung aus Nordrhein-Westfalen und haben eben mit dem NRW-Sonderpreis ein Vehikel geschaffen, das die Einreichung dessen Start-up besonders prämiert und hervorhebt, was eben aus Nordrhein-Westfalen kommt und die beste Leistung hier im Wettbewerb gezeigt hat. Das heißt natürlich nicht, dass dieses Startup nicht auch noch Platz 3, 2 oder 1 im weiteren Wettbewerb belegen kann, sondern gibt lediglich Auskunft darüber, über die hohe Qualität der Startups hier im Bundesland Nordrhein-Westfalen. Bevor ich in einem Augenblick dich, Alexander, bitte, den Staffelstab des NRW-Sonderpreises an den diesjährigen Gewinnern zu überreichen, möchte ich mich von Ihnen, liebe Publikum, verabschieden. Ich wünsche Ihnen allen noch eine spannende Veranstaltung und einen schönen Nachmittag. Es hat mich sehr gefreut. Und ja, machen Sie es gut und eine schöne Woche Ihnen allen. Und nun zurück zu dir, Alex. Ich glaube, jetzt ist dein Einsatz als Beglückwünscher.
Exactly. Wonderful. I did not decide it, but I was so happy to see who was awarded with this award. I'm always happy to see when physical technology is combined with the software and when you see what you can do. And with this team, I'm particularly happy because I feel that they've already spent a long time working on it. It's a hip team, and being a startup from North Rhine-Westphalia, I'm happy to see that colleagues actually receive it. And without any further ado, congratulations to Synteract. And for the special award, wonderful from us as well. Congratulations. This is the certificate. And as said before, the Digital Health Award Special Award, the North Rhine-Westphalian Special Award, goes to the Synteract Smart Glove. And we have Gernot Zimmermann in front of the camera here with us. And I hope that this motivates you to take the next big few steps for your company. Thank you so much. We're so happy that we received the North Rhine-Westphalian Special Award. This is a great motivation for us. Medical device technology can be very long-winded. The certification costs us quite a bit of energy and time, but this is a big step motivating us. Thank you and congratulations. All the very best from us. And I already look forward to be standing on stage with you because by that time we will have overcome COVID largely and to actually hand on the baton to the next special award for North Rhine-Westphalia. Lots of success and lots of motivation for the next year. I'm already thrilled to hear your story next year. Thank you. Well, thanks to you. And we will, of course, follow your story as well. It's fun to watch what companies in North Rhine-Westphalia and in Europe contribute to the big progress of digital development. And to this end, we need such courageous people and such courageous companies. Thank you very much. Have a nice evening. Bye-bye. we have to actually move a little further apart. It is my honor now to introduce the presenter of the laudatory speech. Then we will only have award winners, you know. Rainer Beckers is the CEO of ZDG, of the Telematics and Telemedicine Center, and he is a host as well and a co-organizer. Since 2000, he has been part of ZDG. He started as a head of division and triggered innovations such as the benefit assessment of telemedicine. In April 2009, he was appointed CEO of the ZDG and has accompanied all of the innovations, the great projects that come from North Rhine-Westphalia, and he is a living interface for many, many concerns of young teams and patients looking for solutions. It's very, very nice of you to fill the laudator's vacancy, so to speak. Well, thank you very much for the kind words of introduction. Nobody has ever called me a living interface before, but I do appreciate this because I think this is what it's all about. Because with our Digital Health Congress and with the award ceremony for innovative startups, we want to bring the actors, all of the players together and really put digitalization into practice. And if you allow me to say this up front, I think that we have really succeeded in doing this with this event. It is now my honor to award or present the awards or announce the award winners. And I do not want to dwell on the content because the companies have already presented themselves. But
wenn ich jetzt auf den Platz 3 mal zu sprechen kommen darf, das ist die Firma Asimed aus Frankreich. Da muss man schon sagen, sie trifft gewissermaßen mit ihrer Digitalisierung ins Herz der Medizin, weil sie einen gigantisch großen und extrem wichtigen Bereich der Diagnostik mit ihrem KI-gestützten Tool weiterentwickelt. Und ich bin fest davon überzeugt, dass viele Patientinnen und Patienten von einer schnelleren und vielleicht auch teilweise präziseren Diagnostik durch die KI-Unterstützung in Zukunft profitieren werden. Von daher ein großes Kompliment an dieses Unternehmen und für diese Entwicklung. Und was ich glaube ich, nochmal besonders hervorheben möchte, das wird ja bereits auch schon geäußert, dass dieses System eben mit über 250 Gesundheitszentren weltweit im Grunde genommen auch schon im Einsatz ist. Das ist also eine Innovation im Bereich Deep Learning, die tatsächlich schon angekommen ist. Herr Marx.
Mr. Marx. Well, thank you very much, Mr. Beckers, again from us. Congratulations. And with this, I would like to present the certificate for the third place, the Digital Health Award 2021, and the award goes to the Azimed company and to Caroline Mitterdorfer. Congratulations to you and your team, and I do hope that it will motivate you to be no longer a startup, but an important scale-up. This is what we need for Europe, and big, big thanks on behalf of the patients too.
Thank you very much. Thank you.
Congratulations. Well done.
Ja. Normalerweise würde jetzt der tosende Applaus in einer Präsenzveranstaltung den Übergang markieren. Auf den müssen wir jetzt verzichten, aber ich glaube, die Begeisterung ist spürbar und dennoch vorhanden. dann nehme ich mir jetzt die Freiheit und würde den Zweitplatzierten mal verkünden. Dieses Unternehmen hat sich, glaube ich, eines Problems gewidmet, welches sehr, sehr weit verbreitet ist und auch in der Pandemie unter diesen besonderen krisenhaften Bedingungen, glaube ich, nochmal an Bedeutung gewonnen hat. Die Rede ist von Inuka und ihrem System zur Therapie und Bearbeitung von Burnout in Unternehmen. Und hier kann man, glaube ich, sehr schön sehen, dass digitale Methoden Effizienzvorteile auch haben, Patienten sehr schnell screenen können, Betroffene sehr schnell ermitteln können und ihnen eine Einschätzung über ihre eigene Situation geben können. Und was, glaube ich, besonders innovativ ist, dass es eben gekoppelt ist dann auch mit einem Angebot zur Unterstützung. Und so können ja Hürden für Therapien und Coaching, muss man ja in diesem Fall besser sagen, gesenkt werden. Und ich glaube, dass diese innovative Lösung auch in ganz, ganz vielen Unternehmen, gerade in dieser heutigen Zeit, helfen wird und einen Bedarf trifft und natürlich nicht zuletzt auch eine wertvolle Unterstützung ist für die Mitarbeitenden.
Well, and with this, I have the honor now to present the second place of the Digital Health Award under the patronage of Minister Pinkwart of the Ministry of to Inuka from AME in the Netherlands. And as a representative, I would like to congratulate Robin van Dalen for the whole team and, of course, on behalf of all three organizers. Please, please carry on. Great job. And we already look forward to all the beautiful innovations you'll present to us in future. And we'll follow your development, rest assured.
Ja, dann kommen wir jetzt zu dem Höhepunkt der Preisvergabe. Der Sieger kann benannt werden. Und ich freue mich ganz besonders, dass ich hier eine Firma nennen darf, die sich eines Problems stellt mit digitalen Methoden, welches für die Betroffenen sicherlich oft mit einem ganz langen Leidensweg auch verbunden ist und mit ganz schwierigen Entscheidungen verbunden ist. Und mit Hilfe dieses Systems, das ist, glaube ich, deutlich geworden, können die Betroffenen sehr viel schneller an Hilfe bekommen und vor allen Dingen auch an systematischer Hilfe. Die Rede ist von Lila Fertility. In der Vorstellung des Unternehmens und des Systems wurde bereits deutlich, um welche Problematik es sich im Einzelnen handelt. Und ich glaube, ein wirklich würdiger Sieger an dieser Stelle. Auch Sie haben es auf einzigartige Weise mit Ihrem System geschafft, eine Brücke herzustellen, direkt vom Bedarf des Patienten über digitalen Zugang hin zu einer wirklich umfassenden medizinischen Versorgung. Das ist aller Ehren wert und zu Recht, ohne die anderen jetzt hier, wie soll ich sagen, deren Leistungen in Abrede stellen zu wollen, aber Sie haben hier zu Recht mit Ihrem Ansatz heute den ersten Preis verdient und ich freue mich sehr, dass ich an dieser Stelle diese Worte auch über diesen Ansatz hier entsprechend verkünden darf.
Honor this approach today. Yes, and this is it. The Digital Health Award 2021 goes to Lila Fertility. And as a representative, we have Caroline Mitterdorfer. Congrats from all of the organizers. A great achievement, big applause. Let me briefly follow on what Mr. Becker said in his laudatory speech. Your product is an example of the fact that you have not developed something and then looked for the problem. There was the problem and you developed a solution for it. This is fantastic. Please, please carry on like that. And I am sure that we will see further improvements from your company. Many couples and families really deserve your support. So my heartfelt congratulations. All the very best for your personal future, for the whole team, and for your company. Thank you very much. It's a huge honor for us, and it is really incentive for us to support both men and women. We do highly appreciate what you said, and this is definitely a motivation for us. That's the way it's meant to be. All the very best to you. Well, thank you very much, Mr. Beckers. Well, I'd like to thank you.
Bin ich entlassen als Laudator.
I completed my job. You can stay around if you like.
Ja.
Bye-bye to Bochum. Well, ladies and gentlemen, dear colleagues, the Digital Health Now Congress is drawing to a close. Give me a few last minutes to summarize. I think we saw fireworks of information, of submissions, of welcoming addresses, of ideas. We saw various formats. We had a fantastic hostess, Claudia Dirks, whom I would like to thank. I think this was an important next step in the development. It was really an impetus that is so urgently required to use or leverage the little time left to drive digital transformation for European citizens. And to conclude, I would like to say that the Digital Health Award has again shown how comprehensive this movement is, how European this movement is. It is good to not get everything from Asia or from the US. Good things can be taken over. But the pandemic has shown us in particular how important digitalization is to overcome a major problem. And I am very positive and confident that we will jointly manage to achieve our shared aim, and that is a better patient care and to drive health care for European citizens. Again, to our viewers on the screens, thanks very much for your vivid participation in the chat. I would like to thank all of the speakers, and to conclude, it is a special honor and delight to thank all of the people behind the scenes. And I think we should actually use this time. First of all, I would like to ask Mrs. Claudia Dirks to join me again. And we decided for the classical option, a bouquet of flowers. Oh, thank you very much. I hope the bouquet will survive the trip. It was great to have you. And despite the COVID issues, you actually found your time and way to Aachen. It was so much fun to do this, to spend the day with you. And it was really important for the success of this event. So a big thank you on behalf of all of the organizers. Well, let me return the compliments. The team was fantastic, and we kept the times. But to hear this from you, that you liked it, is great. Thanks very much to the technicians. They did a great job. Thanks very much for the invitation. And to the fantastic speakers. Again, I learned a lot, and that's the way it should be. And this is wonderful for November. Thank you so much. Well, apart from that, I think we've reached the end of this event. What I forgot to mention when I opened this meeting, Mrs. Dirks already said it, we would like to thank the technicians team. It's a complex event and it's a complex cooperation of many, many actors, and it worked out well. It always impresses me. And on the other hand, I would like to thank our sponsors and supporters, because we have been supported by several companies that provided their logos, and without their support, events like these would not be possible, not even in these virtual days. So all for me left to do is to leave you, to wish you a pleasant evening, a wonderful pre-Christmas time. Stay tuned to Digital Health, and I look forward to the 3rd Digital Health Now Congress in 2022. And I do hope, and I'm very confident, that we will be able to have it as a truly hybrid event again, to intensify the exchange even further. So stay safe, and with all the best wishes from Aix-la-Chapelle.